A very good morning to everyone. I request you all to please settle down.
Good morning, ladies and gentlemen. I, Dr. Aman Sharma,
And I, Dr. Deepika Gaur,
on behalf of Ministry of Health and Family Welfare, Government of India, and Quality and Patient Safety Division, National Health Systems Resource Center, welcome you all. It gives us an immense pleasure to extend our warm and heartfelt welcome to all in order to celebrate the 5th World Patient Safety Day on this beautiful morning.
स्वास्थ्य देखभाल की प्रक्रिया में रोगी सुरक्षा का महत्व अतुल्य है और इसी महत्व पर विचार करने के लिए विश्व रोगी सुरक्षा दिवस के उपलक्ष्य में हम सब यहाँ एकत्रित हुए हैं। देवियों और सज्जनों, इस महत्वपूर्ण अवसर पर आप सबकी उपस्थिति ने इंडिया हैबिटेट सेंटर के इस सभागार को और भी भव्य बना दिया है।
World Patient Safety Day is observed on 17th September every year to raise awareness about patient safety and promote actions to reduce patient harm. As the theme of this year's World Patient Safety Day is engaging patients for patient safety, it is an opportunity to anchor discussions and initiatives, the crucial roles patients, families, and caregivers play in the safety of healthcare and ensuring the well-being of patients in India and worldwide.
आज का यह दिन सुरक्षित स्वास्थ्य देखभाल प्रणाली के महत्व और रोगी सुरक्षा के निरंतर प्रयासों को बढ़ाने के लिए प्रण लेने का है। मैं इसी के साथ हमारे चीफ गेस्ट श्री विशाल चौहान जी, जॉइंट सेक्रेटरी पॉलिसी, स्वास्थ्य एवं परिवार कल्याण मंत्रालय, एवं हमारे गेस्ट ऑफ ऑनर मेजर जनरल प्रोफेसर अतुल कोटवाल, सेना मेडल, विशिष्ट सेवा मेडल, एग्जीक्यूटिव डायरेक्टर NHSRC, एवं डॉक्टर नेहा गर्ग, डायरेक्टर NHM2, स्वास्थ्य एवं परिवार कल्याण मंत्रालय से आग्रह करूंगी कि वे आगे आएं और दीप प्रज्वलित करें। Join us on stage.
Now I would request Dr. Jain Srivastava sir, Advisor Quality and Patient Safety Division, NHSRC, to please deliver the welcome address. Over to you, sir.
So, very good morning to all of you. And in fact, the rains are supposed to be an auspicious beginning. जब बरसात हो जाती है तो कहा जाता है कि वो चीज़ अच्छी है, शुभारंभ अच्छा हुआ है. It is my proud privilege and honor to welcome Shri Vishal Chauhan, Joint Secretary Policy in the Ministry of Health and Family Welfare. Sir, I am aware of your schedule that after conducting two important launches by Honorable President, Honorable Prime Minister, returning back in the middle of night and being with us over here today, and I know you have got the back-to-back schedule lined up today, but we are extremely grateful that you could take time out and be with us, and that will be a source of encouragement for all of us. The function, this overall organization and everything has been planned under active guidance and leadership of our Executive Director, Major General Professor Atul Kotwal, who has been a guiding force in this endeavor, whether the quality, patient safety, or any new initiative, whatever we have been planning, he never said no. We are extremely grateful. We also welcome Dr. Neha Garg, Director, National Health Mission. And in fact, frankly, JS sir used to be so occupied that whenever we were stuck with something, I took the liberty of bothering her, whether the clearing file or whatever was needed, and her support has been always there. And we are extremely privileged to have you today morning. And of course, it is very gratifying to see all the states. I mean, the letter which reached to the states Monday late evening, requesting to be here with on Friday morning, traveling on Thursday. And thank you very much to all the states representative who has taken time out to be with us. And I, on behalf of NHSRC and the ministry, extend a very warm welcome to all the states colleagues. We are privileged to have academic institutions, development partners, and our NQASCO external assessor, and many other colleagues. I mean, I extend a very warm welcome to each of you, and your mere presence will go a long way in encouraging and pushing this momentum of the patient safety in the country in a big way. And thank you very much indeed. So without much ado, I would now stop over here, and we look forward to your active participation. And once you go back, we also look forward that what are our doable points and how the quality can be improved, because in our mind, the safety forms the basic foundation of the quality, whatever the system one is using, whether it is NQAS, NABH, or any system for that matter. So thank you very much.
Thank you so much, sir. Now I would request my colleague, Dr. Chinmay Swain, to please welcome Shri Vishal Chauhan, sir, Joint Secretary Policy, Ministry of Health and Family Welfare, India. We welcome you, sir.
Now I would request Ms. Nasreen Nikhat Khan to please welcome Major General Professor Atul Kotwal, sir, SM, VSM, Executive Director, NHSRC. We welcome you, sir.
I would request Ms. Rachna to please welcome Dr. Neha Garg, Director, NHM2, Ministry of Health and Family Welfare. We welcome you, ma'am.
I request Dr. Vinita Dhankar to please welcome Dr. J.N. Srivastava, sir, Advisor, Quality and Patient Safety Division, NHSRC. We welcome you, sir. अब मैं मेजर जनरल प्रोफेसर अतुल कोटवाल, सेना मेडल, विशिष्ट सेवा मेडल, एग्जीक्यूटिव डायरेक्टर NHSRC से आग्रह करती हूं कि आप पेशेंट सेफ्टी के महत्व पर अपने विचार हमारे साथ साझा करें. ओवर टू यू, सर.
Can they start? Could you start my PPT, please, from here? Shri Vishal Chauhan, IAS, Joint Secretary Policy, Ministry of Health and Family Welfare. Dr. Neha Garg, Director NHM2. Dr. J.N. Srivastava, sir, Advisor QPS. Dignitaries in the audience. All the participants from states, my NHSRC team, including the QPS division, which is leading this NQAS effort, and of course the NERRC representatives. Very good morning to all of you, and also all the academic institutions and all who are part of us and development partners. I will just quickly try to put the today's event in context. Of course, there will be technical sessions post tea after the inauguration, but I'll take just 5 to 6 minutes to that. Why do we need to discuss this issue, and why do we need to continuously work on improving the patient safety and quality of healthcare services? So this, we all know that the patient safety is a fundamental element of healthcare. It's a freedom for a patient from unnecessary harm or potential harm associated with provision of healthcare. And it's time now we start using the word community and the population instead of patient, because we are now looking at preventive and promotive as part of the comprehensive primary healthcare. So there should be no harm even for those wellness activities when we talk of. These components you are well aware of. I am not going into details of this, but these 5 the outcomes for assessment, which we all must remember: the errors, the adverse events, infections, injuries, and mortality. That is how we measure, and we need to look at what component, what proportion of all these are because of our quality issues in the healthcare. And why is it important? The burden of harm, if you see 64 million Dalis a year, again these are estimates, and there are people who are challenging these estimates also, but again these estimates are good point to start and address the issue. And globally, the number of preventable deaths, which is visible here, 3 million. The LMICs, of course, there's a talk about the optimal care and also suboptimal care. And again, estimates, that's why there's a wide range, 5.7 to 4 million deaths yearly because of the quality and patient safety issues. Risk of acquiring healthcare associated infections, again, lesser in developed and more in developing countries. And the important issue is that medications is almost 50% of this is due to medication, and more than 50% is easily preventable. Not only preventable, easily preventable. So that's what we need to focus immediately. And unsafe care cost, it's not only the high financial economic cost, it's also the indirect economic and social cost, and also what about the individual. So we must think about the individual when you talk of safety. We should not only think only in the monetary terms, and also the productivity and all the other, the proportion of GDP spent on the treatment and other investigations and all post unsafe care. It's what is the effect on individual, that is also most important thing. We know our country's commitment in after 2015 WHO's regional committee endorsements. In 2016 we decided about the NPSFIS, which was formally launched in 2018, National Patient Safety Implementation Framework. Even National Health Policy of 2017 clearly mentions, patient-centered and quality of care, that is gender-sensitive, effective, safe, and convenient healthcare services. And linked with the universal health coverage, you see the last row down below, attainment of the highest possible level of healthcare and all. And the highlighted word is quality healthcare services without anyone having to face financial hardship as a consequence. So the patient safety and quality is closely linked to universal health coverage. And the key dimensions of UHC, as we all are aware, highlighted only 3 important ones related to quality, accessibility, because that is again very important, and financial risk protection, and quality of services, which increase the likelihood of desired health outcomes and are consistent with evidence-based knowledge, which is to improve the quality of services. Of course, the other dimensions of UHC are well known to everyone present here: the availability, acceptability, equity, patient-centric care, accountability, and addressing all the social and other determinants of health, because that is also part of the universal health coverage. And when we talk of resilient health systems towards which our country is now moving at a fast pace, that requires quality as a foundation. Even universal health coverage is part of the SDGs target 3.8 calls for achieving universal health coverage, including financial risk protection and all. The systems approach is the number one approach when you talk of achieving quality in healthcare, and especially when we want to link it with the universal health coverage. And if you see the systems approach, the National Health Mission as it is ongoing, these 4 pillars of Ayushman Bharat and linked with the grant from 15th Finance Commission, all the other schemes, funding which is available of PMSSY and other schemes of Ministry of Health. And of course now if you look at the Jal Jeevan Mission and Swachh Bharat Mission, the social determinants of health being addressed, the intersectoral coordination and also the community processes which are being strengthened as part of our efforts for health system strengthening. There's a systems approach to achieve the universal health coverage, and quality is a major component of that. And how the continuum of care is now being established with comprehensive primary health care to Ayushman Bharat Health and Wellness Centers, and a continuum and linkages for secondary and tertiary care, for which PMJ empaneled public and private healthcare facilities are there, with the referral gatekeeping, and also the increased number of transport and other facilities, and the subsequent follow-up also at the community level. This is what this diagram shows, that starting from, if you see from the top left side, starting from the population level to the various level of facilities and the various actions being taken, and assured drugs and diagnostics at various levels, increasing number of patient transport vehicles and ambulances, and subsequent follow-up. So that's the kind of the closing the loop for continuum of care which is being planned. And these are the achievements in recent time. There's a huge number of, if you see more than 1.61 lakh HWCs which are already operational. You see the footfalls, the wellness sessions which are being conducted, the hypertension patients numbers on treatment, and these are on treatment. The screened are much more. This is only on treatment. Of course, now we have to look at how many are under control. Same, how many medications dispensed. People who are positive, screened positive post CS, cervical and breast and oral cancer screening. But the primary health care also, we should not be dismissing, or we should not be unaware of the quality and patient safety issues when we talk of primary health care. There's a 20-25% of general population experiences harm in primary health care. Again, estimates. But if you see even the estimates on the right hand side, as I mentioned earlier, 1987 million footfalls. So 20-25% were at potential risk. So that's why we need to look at addressing safe care, and 80% of this so-called adverse events and harm in primary and ambulatory settings is easily avoidable. Cost I have already mentioned, but again when you talk of primary health care, the half of global disease burden arising from patient harm originates in primary and ambulatory care. So and it's comparable to many of the communicable disease burden. The direct cost, if you see the OECD countries, I mentioned 2.5% total health expenditure because of the primary health care direct harm, because of additional tests, treatment and health care. But again, to reiterate what I mentioned earlier, the individual, society effect, and also the loss of trust and faith in case of the patient safety, adverse patient safety and quality issues at the primary health care. The increasing numbers which people are now coming to public health facilities, we may lose their trust if we don't address the patient safety issues at the primary health care level. Strategies again well known to you all. Just a quick thing, that patients / community engagement. So that's why the Jan Arogya Samitis and VHSNCs, and they need to be strengthened even for the quality aspects. The human resource for health, their capacity building, and also their humane, not human factors, the humane factors and all, that need to be addressed. Digital tools, we all are aware how to utilize those. The reduction in diagnostics errors, medication errors, and multimorbidities again are a major risk for patient safety of errors. Transition of care and also administrative errors. So these are guiding principles, and these are well known to you all. The overall health systems approach, where we look at the leadership, governance, health services, workforce, financing, equitable access to essential medicines and drugs and production technologies, and also the sustainable and monitoring progress, the evidence-based interventions. But the last one, if you see the wellness, that's what I think we also need to address it. The newer, in fact, Ayush wellness activities which we are now integrating as part of the healthcare, their safety protocols also. We need to look at all these when we talk of quality and patient safety. So we have a framework, we have the structural system for quality and patient safety, we have assessment and scoring, reporting of adverse events, but again the pharmacovigilance and material vigilance and all, how effective they are. So those also need to be strengthened, not only the certification of NQAS and all the other, it also are the grievance and reporting systems also need to be strengthened. The competent and of course capable workforce cannot be stressed more. The control of HAIs, patient safety access across all programs, and of course the research. That's again, you see, the second slide which I showed you was more of estimates, and now people are questioning those estimates, that probably those estimates have been taken from smaller studies. For a particular group of patients beyond 60, which are more than 65 or more than 60, they were non-ambulatory. For primary care also it is taken from a different subset, and it is being generalized. That's why we need more research to generate more evidence of the effect of the unsafe and lack of quality wherever it is there in the patient safety, and also how that will improve the safety and quality will improve the outputs and outcomes. These are the initiatives current now of Ministry of Health and Family Welfare to improve patient safety and ensure quality health care. NCOS, Lakshya and Muskaan, Kayakalp. Sakushal is the self-assessment tool which a lot of states have already utilized and seen what are the gaps and how can they fill up those gaps. And of course, there is something new which is yet to be approved, yet to see the light of the day, but already the work has already been done. The NCOS lab with the large number of integrated district public health labs and block public health units coming up. With that, I'll stop here. Thank you very much. I just want to put it in context that why we are here and what we need to discuss during our technical sessions. Thank you very much.
Thank you so much, sir, for sharing your inspirational thoughts on patient safety. Now I would request Shri Vishal Chauhan, sir, Joint Secretary Policy, to please administer the patient safety pledge with one and all present here and to the nationwide who have joined us remotely.
शपथ पहले हिंदी फिर उसके बाद इंग्लिश में होगी। मैं आप सबसे निवेदन करती हूँ कि अपने अपने स्थान पर खड़े होकर हमारे साथ शपथ ग्रहण करें।
विशाल चौहान, जॉइंट सेक्रेटरी पॉलिसी, शपथ लेता हूं कि मैं अपने स्वास्थ्य केंद्र अपने समाज और राष्ट्र में रोगी सुरक्षा को प्रोत्साहित करने के लिए हर संभव प्रयास करूंगा, जिसमें उपचार के दौरान दवाइयों से होने वाले नुकसान को समाप्त करने पर विशेष ध्यान दिया जाएगा। मैं स्वास्थ्य सुविधाओं को सुरक्षित बनाने हेतु महत्वपूर्ण भूमिका निभाने के लिए प्रतिबद्ध हूँ, जिसके लिए मैं निम्न प्रयास करूँगा। रोगी के उपचार के समय होने वाली कमियों की पहचान करके उन्हें पूर्ण रूप से समाप्त करने हेतु प्रयासरत रहूंगा। रोगी सुरक्षा से संबंधित सभी विषयों पर स्वयं के ज्ञान को बढ़ाते हुए अपने कार्यकौशल में सुधार लाऊंगा। चिकित्सीय उपचार में रोगियों और उनके परिवार के सदस्य को सक्रिय रूप से भागीदार बनाऊंगा। रोगी सुरक्षा के बारे में सामूहिक जागरूकता बढ़ाऊंगा। सामूहिक सहयोग के माध्यम से स्वास्थ्य सेवाओं में पारदर्शिता का समर्थन एवं प्रचार करूंगा। स्वास्थ्य सेवाएं प्रदान करने में हुई त्रुटियों से शिक्षा ग्रहण करके स्वयं में सुधार लाऊंगा। रोगी सुरक्षा को बढ़ावा देने के लिए अपने सहयोगी द्वारा किए गए प्रयासों का समर्थन करूंगा। थैंक यू। नाउ विल टेक इन द इंग्लिश। I, Vishal Chauhan, hereby by pledge to undertake all the actions for promotion of patient safety in my health facility, community and country. I commit to dedicate myself to make healthcare safer by supporting but not limited to following actions, namely identification and implementation of the ways to reduce errors in patient care, improving our skills and knowledge on all related subjects
on all related subjects
pertaining to patient safety,
pertaining to patient safety,
actively engaging patients
actively engaging patients
and families as partners in their care,
as families and partners in their care,
raising public awareness about patient safety,
raising public awareness about patient safety,
nurturing, supporting and promoting transparency
and promoting transparency
in care through teamwork,
team,
learning from errors for safeguarding
learning from errors for safeguarding
interest of patients and
interest of patients,
supporting my professional colleagues
supporting my professional colleagues
in their endeavor
in their endeavor
of promotion of cause of patient safety.
of promotion of cause of patient safety.
Thank you.
Thank you. Thank you so much, sir, and thank you all. With this, I would request Shri Vishal Chauhan, sir, to please release the posters of patient safety by pressing the button of the remote. The first poster is on patient safety and community engagement. The second poster describes the role patients and families and caregivers play in the healthcare safety. Thank you so much, sir.
अब मैं श्री विशाल चौहान जी जॉइंट सेक्रेटरी पॉलिसी से आग्रह करती हूँ कि वो रिमोट का बटन दबाकर पेशेंट सेफ्टी अवेयरनेस की वीडियो को रिलीज करें।
रामू एक मजदूर है जो लंबे समय से धूम्रपान करता है।
आजकल काम करते समय मुझे सिर में दर्द रहता है और कभी कभी चक्कर भी आते हैं।
ये तुम्हें इन दिनों गर्मी अधिक होने से हो सकता है।
स्थिति वैसी ही बनी रही और 10 दिनों के बाद रामू पास के प्राथमिक स्वास्थ्य केंद्र में गया।
राम राम डॉक्टर साहब।
आओ आओ बैठो। क्या नाम है तुम्हारा और क्या परेशानी है, ठीक से बताओ।
डॉक्टर साहब, मेरा नाम रामू है। मुझे कुछ दिनों से बहुत सर दर्द हो रहा है और चक्कर जैसा भी लगता है।
अच्छा रामू, ठीक है, मैं तुम्हारी जांच कर लेता हूँ।
डॉक्टर ने उसकी जांच की।
रामू, तुम्हारा रक्तचाप अधिक है। मैं तुम्हें दवा दे रहा हूँ, जिन्हें समय से लेना और 1 हफ्ते बाद आकर मुझे फिर दिखाना।
ठीक है डॉक्टर साहब, धन्यवाद।
रामू घर वापस आ गया।
डॉक्टर ने क्या कहा?
डॉक्टर ने कहा है कि ये उच्च रक्तचाप के कारण है। उन्होंने मुझे नियमित रूप से दवा लेने को कहा है और 1 सप्ताह बाद फिर से आकर दिखाने को भी कहा है।
अच्छा, ये उच्च रक्तचाप क्या होता है?
ये तो मुझे नहीं पता और मैंने डॉक्टर से भी इसके बारे में नहीं पूछा। अगली बार जाऊंगा तो पूछ लूंगा।
ठीक है, अपनी दवा लो और तुम बिल्कुल ठीक हो जाओगे। चिंता की कोई बात नहीं है। हो सकता है ऐसा इन दिनों बढ़े हुए तापमान के कारण हो रहा होगा।
रामू ने लगातार 1 सप्ताह तक दवा ली और उसे अच्छा महसूस हुआ। तभी उसकी दवा खत्म हो गई।
शीला, मेरी दवा खत्म हो गई है। क्या मुझे दोबारा प्राथमिक स्वास्थ्य केंद्र जाना चाहिए? डॉक्टर ने मुझे 1 सप्ताह बाद आने को कहा था।
अच्छा सुनते हो, अगर तुम्हें अब ठीक लग रहा है तो क्यों जाओगे? अपनी खेती का काम संभालो।
कुछ दिन बिना किसी लक्षण के बीत गए। कुछ दिनों के बाद रामू को फिर से तेज सिर दर्द होने लगा।
आज मेरे सिर में फिर से बहुत दर्द हो रहा है।
ये दवा ले लो। पिछले महीने मेरे सिर में दर्द हुआ था तो बिमला ने मुझे दी थी। ये बहुत अच्छा काम करती है।
ठीक है, मुझे दे दो।
दवा लेने के बाद रामू की त्वचा पर कुछ चकत्ते पड़ गए, लेकिन उसने उन पर ध्यान नहीं दिया और सो गया। अगली सुबह रामू चक्कर खा के गिर गया। शीला उसे प्राथमिक स्वास्थ्य केंद्र ले गई। वहां डॉक्टर ने रामू की जांच की और पता चला कि उसका रक्तचाप 180/120 तक पहुंच गया था। डॉक्टर ने रामू की त्वचा पर पड़े चकत्ते भी देखे।
रामू, क्या तुम समय पर नियमित रूप से दवा ले रहे हो? मैंने तुम्हें 1 सप्ताह बाद फिर से आकर दिखाने को कहा था। और तुम्हारी त्वचा पर ये चकत्ते कैसे हुए?
डॉक्टर साहब, मैंने 1 सप्ताह नियमित रूप से दवा ली और मुझे ठीक महसूस हुआ, इसीलिए मैं फिर से दवा लेने नहीं आया। कल रात मुझे सर दर्द था तो मेरी पत्नी ने मुझे एक दवाई दी। उसको लेने के बाद मेरी त्वचा पर चकत्ते हो गए।
तुम्हारे डॉक्टर की सलाह के बिना दवा छोड़ देने से आज तुम्हारा रक्तचाप बहुत अधिक बढ़ गया, जिसके कारण तुम चक्कर आने से बेहोश हो गए। और तुम्हें तत्काल आना पड़ा, और तुम्हारी त्वचा पर ये चकत्ते भी बिना डॉक्टर की सलाह के गलत दवा लेने से हुए हैं।
रामू और शीला ने बीमारी और उसके कारणों के बारे में पूछा। डॉक्टर ने उन्हें समझाया। डॉक्टर ने शीला को रामू को समय पर दवा लेने और स्वस्थ जीवन शैली बनाए रखने में मदद करने के बारे में भी सलाह दी। डॉक्टर ने समझाया कि मरीज की भागीदारी से मरीज की सुरक्षा होती है। जरूरी संदेश: अपनी बीमारी एवं दवा की सही जानकारी अपने डॉक्टर से जरूर लें। बिना डॉक्टर की सलाह कोई भी दवा अपने पड़ोसी या मित्र से लेकर ना खाएं। सही दवा सही वक्त पर उचित मात्रा में पर्याप्त अवधि तक लें। रोगी की भागीदारी ही रोगी की सुरक्षा की ओर पहला कदम। स्वस्थ रहें, सुरक्षित रहें। आपका स्वास्थ्य, आपकी सुरक्षा, हमारी प्राथमिकता।
थैंक यू सो मच सर। अब मैं श्री विशाल चौहान जी, जॉइंट सेक्रेटरी पॉलिसी से निवेदन करती हूँ कि वे हमारे पेशेंट सेफ्टी चैंपियंस को सम्मानित करें। इन सभी राज्यों ने सकुशल सेल्फ असेसमेंट टूल फॉर हेल्थ एंड फैसिलिटीज़ के उपयोग करके रोगी सुरक्षा के आंकड़ों को जनित किया है। वे सभी चिकित्सा संस्थानों को रोगी सुरक्षा के लिए एक कदम बढ़ाया है। अब मैं निवेदन करूंगी आंध्र प्रदेश टीम से, कृपया वो स्टेज पर आएं।
I request the audience to please put your hands together for the team's outstanding effort and dedication towards patient safety.
Now I will request the team of State Assam to please come forward. Now we request the state of Bihar to please come forward. Now I request the team from state of Chhattisgarh to please come forward.
Now I request team from Dadar Nagar Haveli and Daman Diu to please come forward on the stage. I would also request team Delhi to please come forward. Team from the state of Haryana, please join us on the stage. Team from the state of Gujarat, please join us on the stage. Team Gujarat. Team Haryana, please come forward.
Now I request the team from Jammu and Kashmir. I request the state team from Karnataka to please come forward. Now I request the team from state of Kerala to please join us. Now I request the team from Madhya Pradesh to please come forward.
I request the audience to please keep clapping for these states. I request Team Odisha to please join us on the stage. I request team from Puducherry to please join us on the stage. I request team from state of Rajasthan to please join us on the stage. Now I request team from the state of Sikkim to please join us on the stage.
Now I request the team from state of Tamil Nadu to please join us. Now I request the state team from Telangana to please join us. Now I request the team from Uttarakhand to please join us. Now I request the team from West Bengal to please join us. Congratulations to all the states and thank you all dignitaries.
With this, I would also like to inform that due to some unavoidable circumstances, the teams from the states of Jharkhand and Mizoram have not been able to join us today here physically. We extend our heartiest congratulations to both states as well. Moving ahead, I would request Shri Vishal Chauhan sir, Joint Secretary Policy, Ministry of Health and Family Welfare, to please address one and all present here.
ED NHSRC, Major General Dr. Professor Atul Kotwal, Dr. Neha Garg, Director from the Ministry of Health and Family Welfare, Dr. J.N. Srivastav, Advisor Quality Processes Services, Dr. Hilde from WHO, Dr. Preeti Kumar, Director IIPS Delhi, and all the senior officers, quality nodal officers, state program managers and others senior officers involved with quality who are present in this hall. It's really a matter of great satisfaction that we could assemble here, in spite of so much of hectic schedule, we could assemble here and discuss about very core issue of quality, which is very, very important and goes always along with the patient safety. Our National Health Policy 2017 talks about quality in detail. And after that, we had Patient Safety Implementation Framework from 2018 to 2025. That gave us a framework and the roadmap how to ensure quality in our services and in the patient services and in the patient safety. We started this process long back, and now we have come a long way. We initially had NQAS, then we had Lakshya, then we had dialysis services, patient safety standards, then we had labor room and operation theatre labor standards, then Musbi brought Muskan also. So a lot of initiatives have been taken. And I could see that in the last 1 year, there has been a significant awareness and the enthusiasm about the quality, and it is very, very important. In the last 1 year, I think we have done a lot number of patient quality certification for our facilities. I think almost 50% of our facilities which are certified are done in the last 1 year or 1.5 years maybe. We have done very well as far as the district hospitals are concerned. About 50-60% of the district hospitals in the country are quality certified. But as we go to the other facilities, sub-district hospitals, CSCs, the numbers are less. And when we talk about health and wellness centers and the PSCs, the number is even less. So hardly the health and wellness centers, the patients, and this quality certification is only 2 to 3%. So this is a low-hanging fruit, and we need to do more. I have always been saying that involvement of ensuring quality certification it does not cost a lot of money. It is more about the work culture, about the safe practices, about the training, and how do we follow the protocols. And I always say that quality always results in quality does not mean more cost, quality means saving in cost. So we have to ensure that if we ensure in our waste disposal practices, if we ensure quality in our how waste is disposed, how we take action, segregation of waste, how we ensure that our drugs are kept, can we ensure that expiry drugs are removed. So Dr. Kotwal talk about all these things in detail. I will only tell you about the policy level issues is that in the National Health Mission extension, what we have committed ourselves that by 2025-26, 50% of the health facilities in all the states will be quality certified. So we need to cover a lot of distance as far as the quality is concerned. Also, when we had a second Chief Secretary's conference in which Honorable Prime Minister Sir was there as a chairman, it was mainly about the non-communicable diseases and about the nutrition. But Honorable Prime Minister himself brought this agenda of quality forward and said we have to ensure quality services. And then if you see in the minutes of the meeting, what decision has been taken is that by 25, we have to ensure 50% of the facilities are quality certified, but by 2027 we have to ensure that 100% of the facilities have to be quality certified. For quality and for meeting the public health standards requirement, we have given untied funds to the state, where if some toilets have to be made, or some seepage has to be removed, if some repair has to be done, health facilities should have flexibility to ensure that these things are taken care of, because sometimes it involves some money, but it is not always. I always give example when we shift the patient, sometime the dispatch slip is lost, sometime it gets exchanged, and then there harms to the patients are there. So I always say it is more about how do we ensure the protocols are followed, how we ensure that drugs, diagnostics are prescribed, recommended, and patients are counseled. In fact, our oath tells everything about what we need to do. So we have an ambitious target that by 25 we have to achieve 50% of the facility. By 27 we have to achieve 100% of the facilities. Two new initiatives we are planning, very actively considering in the ministry. One is that at least in the health and wellness centers, if we can have a online kind of a inspection, because it requires lot of, I'm told it requires sometime lot of cost and money and time in inspections and sending team, and they are required to stay at some places, then obviously accommodation cost, transport cost, and all these things are there. So can we make a hybrid kind of a system where 100% verification is done online and some is done on a sample basis in a physical mode, so that we can ensure the quality standards but also save time and money. So that is one way we are thinking. Will require states also to give their suggestion on this issue. Second thing we are saying, we are creating lot of new facilities. Why can't with Dr. I think it came in the presentation of Dr. Kotwal also. Why can't from day one we can ensure quality certification for these facilities? We are making block public health unit, we are making integrated public health lab, we are creating critical care blocks, we are creating health and wellness centers. These are new buildings, so it should not have problem of seepages, or they should be designed as per the IPHS norms, as per the quality norms. So while construction itself, we ensure that they comply to the all quality norms, all IPHS norms. So from day one, infrastructure wise, they are complying to the quality standards. Then human resources also, while the existing manpower is posted or new is recruited, can they be trained well in advance in the protocols, in the practices? So whether a new district integrated public health lab is set up, this is a suggestion and direction given by our Secretary Health, Mr. Sudhansh Pant. So sir had told that why can't from day one only we have facilities as quality certified. So I am sure that my team in the NHSRC is working on this, so that we can achieve those standards from day one in the services, whether it is critical care block or it is integrated public health lab. So I'm very happy that 22 states are using Sakushal app or portal, in which we are doing kind of a self-assessment, and that's really very good that we come to know that where do we stand and how we can improve, which are the areas where we are lacking. It's a self-learning tool also, it's self, for understanding also. I'm also told that now Sakushal portal is more or less working, and whatever changes are Saksham portal is more or less working. If some issues are there, we can resolve it, and we can ensure that most of the things we can do online, so that we know when assessment is done, when it is sent here, how much time it is taken, all these things, what are the comments so far, what are the conditionality. One more thing in the last I want to say that many of the facilities which were certified 3 years back or 4 years back, the certification has expired, and we have not made enough efforts to ensure that they are recertified. And also some of the facilities are conditional certified for probably 1 year, and then also we have to ensure that that conditional become a absolute kind of a certification. And also we have to work in advance before the certificate get expired. So with these words, I wish this workshop a very, very success. I am told, I can see very eminent people are present here who will be talking about, will be sharing their experiences. And also we will hear from the states. I wanted to sit the throughout session, but there are so many other programs. Tomorrow also there is a program in Agra where Honorable Minister Sir is coming to Uttar Pradesh. So I will not be able to sit throughout, but obviously the proceedings come to us and we go into detail. We value each and every suggestion given by the state team. So with these words, I wish this conference, our workshop, a very, very success. Thank you very much.
Thank you so much, sir, for your kind words. अब मैं डॉक्टर नेहा गर्ग, डायरेक्टर NHM 2 स्वास्थ्य एवं परिवार कल्याण मंत्रालय से वोट ऑफ थैंक्स के लिए आग्रह करती हूँ।
respected dignitaries on the dais, and all the eminent experts and colleagues who are here present in the hall with us today. It is my privilege to propose the formal vote of thanks for this very important celebration of the for the International Patient Safety Week that starts on 17th. First and foremost, I would like to express my thanks to Shri Vishal Chauhan, Joint Secretary Policy, Ministry of Health and Family Welfare, for his guidance, leadership, and unflinching support, because of which such newer and very pertinent initiatives, such as those for patient safety, are conceptualized and taken to the execution. I would also like to thank Sir for sparing his valuable time, despite his very busy schedule, and being with us here today in the morning. I would also like to express my thanks to Major General Professor Atul Kotwal, ED NHSRC, for his visionary and able leadership and leading NHSRC and guiding the team, and for seamless coordination and collaboration with the Ministry of Health, and also his ever-present help and guidance for the state teams. Then I would like to thank Dr. J.N. Srivastava, Advisor, Quality and Patient Safety, NHSRC, who with his wide experience, wisdom, and dedication is the primary driving force behind the quality program of Ministry of Health. And his passion is something that we all can learn from. I would also like to thank the state officials of the 20 teams who have started using the Sakushal tool, which was launched at the Patient Safety Week last year. I also thank the 18 state teams that have made it to this program. And I hope that you take back the message of patient safety and work with renewed vigor in this field. I would also like to express my thanks in advance to the eminent speakers who you all would be hearing from in the technical sessions to follow. Thanks is also due to the external assessors who, not only for their presence, but also for their untiring work that they're doing in the field. It is because of you all that, as Vishal sir mentioned, the quality certification has really picked up speed in the last year. Then the people who really put in all the work, the quality and patient safety team at NHSRC, your work is appreciated, and we are all grateful for all the work that you put in, the long hours that have been put in for this program, and not just today, throughout the year. I also thank our team at the Ministry of Health, who also are working consistently round the clock to ensure that the quality targets that have been set by the highest officials are fulfilled. No program is complete without the administrative support, so thanks are due to the administration team at NHSRC, led ably by PEO Brigadier Sanjay Baveja, and the team of IHC as well, the management that has helped put together the program for today. I would also like to thank, last but not the least, Dr. Aman and Dr. Deepika for seamlessly putting together this program. Thank you very much.
Thank you so much, ma'am.
With this, I request one and all to please assemble at the plaza stairs for a group photograph followed by tea break. The tea is being served at the Silver Oak Hall. I request my team members to please guide everyone towards the stipulated places.
And we have also organized a small quiz, that is Kaun Banega Patient Safety Champions, outside the auditorium near the entrance. I request you all to please participate.
Kindly assemble back by 11 as we have our technical sessions planned after the tea break. Thank you so much.
Thank you so much.
welcome Dr. Jain Srivastava, Advisor Quality and Patient Safety. Please welcome Dr. Indu Arneza.
पहले ये वाली लाइन तो बोलेगा तू.
सेटल डाउन होने के लिए बोल दो. तू बोल. नहीं आप बोलोगे. आप बोलोगे.
I request you all to please settle down.
We'll be starting with the technical session soon.
कभी WhatsApp पे कुछ चल ना जाए.
तो अपनी लाइट बंद है. स्क्रीन पे आ गया. जैसे सर इशारा करेंगे तो मेरे को बता देना. शुरू करते हैं. एक बार और अनाउंस कर देंगे. एक बार रिजॉर्ट वाला तो टाइम बोला भगवान ने रिजॉर्ट में. बोला है सर. बोला है सर ने दोनों का. दीपिका मैम को भी बोल दिया उन्होंने. एक बार पूछ लेना मैम से. सर इशारे करेंगे सर. एक बार फिर से बोल दो. फिर से बोल दो.
I once again request you all to please settle down so that we can begin with our technical sessions.
Ladies and gentlemen, as the inaugural session is over, I welcome you back to embark the second half of this event, which includes technical sessions by our eminent speakers from across the country who are experts in their own domains related to patient safety and community engagement. I request all the speakers to please join us on the stage. Please welcome Dr. Jain Srivastava sir, Advisor Quality and Patient Safety Division, NHSRC.
Please welcome Dr. Indu Arneza, Director, Indian Institute of Healthcare Communication.
Please welcome Dr. Sangeeta Sharma, President, Delhi Society for Promotion of Rational Use of Drugs and Professor and Head. Okay, sir.
Now I welcome Dr. J.S. Arora, General Secretary, National Thalassemia Welfare Society.
I also welcome Dr. Ratna Devi, CEO, Dakshama Health, Director, Patient Academy for Innovation and Research, Founder. Also, I welcome Dr. Deepika Sharma, Lead Consultant, Quality and Patient Safety Division, National Health Systems Resource Center. To begin with our technical sessions, I would like to invite Dr. Jain Srivastava sir, Advisor Quality and Patient Safety Division. Sir has advanced qualifications in medicine and health systems management. He and his team leads quality improvement initiatives of Health Ministry of India. Under his leadership, the National Quality Assurance Standards (NQAS) for every level of primary and secondary care facilities have been developed. He is also an elected member of National Academy of Medical Sciences and founder member of Indian Society of Hospitals, Waste Management and Health System Networks. Sir, I would like to invite you for giving us an overview on patient safety and global scenario. Over to you, sir.
Thank you, Aman and Deepika. Now my team always puts me in difficult situation. They are fond of doing. And they always tell, I normally leave them that what you want me to do. And it is them, they said, no, why I am telling, among this gathering with so many experts and the people who are working at the global level, like, I instantly recall Dr. Hilde in the front row, and Dr. Arora, Dr. Ratna Devi, they are just back today morning after attending a WHO conclave in Geneva, and Dr. Indu Arneja. So they are have got the knowledge and experience, and they have been the part of this endeavor as such. But since I have been given a topic to talk, so 5 to 7 minutes, 10 minutes, we'll take you through. On a serious note, not too many months back, you may recall that on 2nd June this year, a very tragic accident happened in the state of Odisha, district of Balasore, where the 3 trains collided. Whatever I don't want to go into the reasons, but the take-home message is that can someone recall, live beside the Odisha, that how many people they lost their life as per the government data? When the government has put around 294, I am sure that figures may be a bit higher. About 1500 odd people, they sustained the major injuries and something more. I don't want to undermine by no set of the imagination about that tragedy which struck all of us, and more so those who were traveling in these 3 trains. And the ministers' concerns getting articulated, and everybody visited also. But imagine that this type of situation happens in our healthcare, in our hospitals, whether it is, leave besides the ownership, whether it is the government, private, irrespective of that level of the facility, tertiary, secondary, primary, those are the academic, normally one divisions. Broadly, that is my perception. You may have the difference of opinion. But only thing is, it is happening maybe that by the broad, some just guesstimate, I would say, not the estimate, about 10 times, 100 times more, but at a slower pace, highly unrecognized, but hardly it gets spoken, gets discussed. And more importantly, any learning taking place. I also take this opportunity to welcome Dr. Sangeeta Sharma. Ma'am, aiye, please, your seat is still waiting for you. So, the short point I am trying to make, that learning, like our Indian Railways learned so much, and still under the leadership of Honorable Railway Minister, the things are being put in place, whether it is for the signaling system, and lot of changes are taking place, including planning for putting a Kavach in all the trains. Kavach is basically, those of you may not know, the anti-collision device, which every train is supposed to be having. But what are we doing for our hospitals? And what are our learnings? This is the point I want to in the beginning. Now all of us are in some way or other responsible for promoting the quality, safety, and we have the due support also coming up. Gradually it is coming. I would not say that thing. And more so it becomes a concern which our ED, General Kotwal, spoke in the primary care. Like we have got community health officers, lot of emphasis is there on the palliative care, lot of the drugs having the lesser safety margins are required to be administered in the home setting. We also know that the number of the drugs, Dr. Sangeeta Sharma will bear me out, increases as with the longevity of life. What about the drug interactions, people being on the long-term catheter, So issues are many. I mean, the short point is that. And let's do some introspection and see that what we can do, what you can do. That is in fact the start message which I wanted, that what I am feeling must convey. Now coming to the formal part of my presentation. So we all know the magnitude of the problem, these statistical data. All of you can go through. The short point again I am trying to make, that it is a grossly underreported thing. Grossly. And I would urge all the states particularly, if you wish, you can propose a small study in your NHM PIP, which you will be submitting, you will be preparing this month, next month. That is an ongoing work. The schedule has already come in. Plan for certain studies and let's have certain basic robust data. That where do we stand? Our problem is that in India as of now we don't have, in the real sense, the primary data available on the extent of the harm. And though, I mean, the different figures are available, and somewhere it is between say 40% to 10%, 8%. But with our population of 140 crores, you can multiply, and with these many footfalls which our ED shared in the morning in his one of the slides, that as per the SWC portal, how many people have accessed the health facilities, that what possibly the harm would have happened. I mean, being a medical professional, we all know, and those of you who have been in the clinical practice would recall, that certain amount of the drug interaction, adverse event, side effect, whatever name with the clinical definitions you want to give, you can give. But about 50% of these things are preventable. Are we doing enough to prevent these things which are preventable? Like, I mean, in the lighter vein, to give an example, yesterday I just talked to my team. I said, okay, tomorrow I don't get involved into the nitty-gritty. I said, is there any pain point? And is there something which is doable now? So, which I want to convey is that let's try to identify certain doable things. There is enough global learning available, there is enough learning available within the countries, and the data has started flowing. In subsequent part of the presentation, a few slides, I'll be sharing with them. Diagnostic errors. It is not only that false positive, false negative, we all know it happens. But accuracy of the reliability of the report. Why does it happen that those of you who are coming from the higher institutions would recall that when the patient comes, he or she will carry a big bundle of the investigations, but the doctor invariably writes the repeat investigation. And the challenge is twofold. One is there is a delay in the reconfirming the diagnosis, and there is a cost involved. I mean, still in the country, about 26% of the out-of-pocket expenditure is on the diagnostics. And of course, the 65% remains on the drugs. So, it is not the consultation. It is not the HR cost. It is on these two things, which happens. I mean, you can go through the NSSO figures or the national health accounts, which in fact in NHRC, our colleagues, they handle on day in, day out basis. Okay. These are the figures which WHO has put, and these are the things, in fact, I have taken with the due acknowledgement from their figure, and they are talking about the globally. But the short point is that the picture is emerging across. The type of the challenges may be different in the advanced countries or in the more developed countries, or in the country like India, which is in the middle path, that we have made a journey, but our certain population in the certain pockets, there is a good progress. And at higher level, as I said, technical person. Okay, at a higher level, everyone has in the system has their priorities. At the higher level, they are looking at the numbers, no two doubts. It is their mandate, their agenda. But as a technical person, as a technical advisor to your state, your organizations, please start looking at the certain outcomes. You can pick up very small things, whatever is doable. And there's the definitions which are available. And unsafe care in India, this is in fact again the data source is given, but I'm sure that many more things could be added upon. That rough estimate is about say 52 lakhs, but I would put around 1 crore, double the amount. Those are the potential harms which the country is facing. Okay, and this is a paper, interesting piece of information which my team picked up on financial implication. Like all of us talk, just please pay attention on the last row and on the last column, where it is estimated that about, we are more accustomed talking in terms of the crores and other things, that about 3,300 crore is the estimated loss. Because after all, there is those of you who are coming from the states who recall that everything percolates down to our resource envelope, whether under NHM or within your state budget. But otherwise also it is estimated that about 15% of the hospital operations cost. We have got, reputation from Academy of Hospital Administration and many other experts. The figure may vary, but 15% of the hospital operations cost is in addressing the issues arising out of the patient safety. So this is a challenge, and WHO, again, way back, initially it was the first challenge which started on the cleanliness way back in 2005, and now we are in 18 years have gone by. How good or how bad are our hospital waste management practices? I leave it to your wisdom. I don't want to be judgmental, but at the same time, please think over it. How much progress have we made? How much time do we really need? First time the biomedical waste rules came in 1998, revised edition in 2016, and subsequent amendments in the COVID time, but actual practices. So biggest three challenges in the country are hospital acquired infections, medication errors. These are the two bigger challenges which are there. So in 2019, WHO passed a resolution where the DG WHO was, in fact UN passed the resolution whereby the DG WHO was requested to urge every member countries to come out with an global safety action plan, and India is also one of the signatories in that. Subsequently, the global patient safety action plan was formally launched about say 2 years back, and there is in fact one of the things, being the part of the technical expert, and there are many others also, every country is required to be assessed objectively. There is a set format, but that has to be still, when that format comes, then we start looking around that on every attributes or everything, where do we stand. There are 7 strategic objectives which are well articulated in the format, but the root cause of every error is always the Swiss cheese model, and majority of the errors are due to human errors and very difficult to address. And unless we address these, I am afraid that our outcomes may not improve to that level. This is again, it gives the chronology of the event. The source is given at the bottom, that how the India as a country is started around same time in 2005 when the NHM was launched, and subsequently at different level. Our bigger problem is that our efforts are disjointed. Whether it is the private sector, government sector, not-for-profit sector, within the government, tertiary care, primary care, NHM, non-NHM, but let's get into the habit of looking at the health system issue. That is the individual's choice and paying capability, that where does one to go to avail the things. Similarly, like NHSRC came into the existence in 2008, 7-8, and whatever we could do, we tried to do, including the NQAS framework. And again, with due apologies to Dr. Hilde, for us, quality, patient safety, and the cleanliness is all interlinked. Whether in our language, whether it is NQAS or the Kayakalp or the patient safety, everything is joining. But in our organization, the things are looked differently. Okay. So, as mentioned in the morning, about say 5 years back, this National Patient Safety Implementation Framework was launched in one of our Kayakalp function. And this, in fact, please remember, this was launched in fact in 2018, if you have noticed, in April, while the WHO was asking for the country to come out was much later. We are quite good in coming out with the guidelines. I am very honest and candid in talking as a technical colleague. But there are 6 strategic objectives which are identified, and let's quickly touch upon what are these. So these are the priority areas which talks about, and over here in the states, the safety has been clubbed together, and what we are trying to do, and there is a challenge. I mean, all of you can go through. Challenge is still we are working in a bit of silos, lot of silos, that we are not engaging with the non-government sector. And unless we engage with the non-government sector, perhaps our things. And whatever we could do, activity under NQAS, that is highlighted in the, in this slide, in the column number 3, where like at the central level, we have got the Central Quality Supervisory Committee, and the decision was taken that the patient safety would be for the hospitals, district hospitals and lower facilities, that will be steered through them. And at the state level, we have got the SQSCs. And ministry has already written that the safety should be included as a part of this thing. Though within this framework, the safety is quite inbuilt, robust, but still we realized that let's have a separate patient safety assessment tool, and which was launched last year on the patient safety day only. On 16th September last year we had the function, and there is recognition of the states which took place in the morning inaugural session are those people who have made a beginning, at least have started making a self-assessment on that tool. I would again urge that fine, at NHSRC we are happy that you have shared the score with us, but I would urge that kindly go back. Look at that, what are the major gaps which are coming out in that assessment? Which are the things which are doable? Doable means that, like if we talk the prioritization tool in the quality, that what needs to be addressed immediately, which is affecting my patient care, which is affecting my outcome, and which can be done within the available resource with some technical support. I would urge, in fact, many development partners are present over here, that let's collectively reach out to the states in terms of expanding the scope of the quality, including safety, including infection control, biomedical waste. So for us, NQAS, then Sakushal, and then activities under the Kayakalp, everything is subsuming, getting mud, because everything, all these initiatives, whether the Laksh, Muskan, all these somewhere helps us in attaining the better outcome. I am a strong believer that certification is important, no two doubts. Somewhere the numbers are important, but unless my outcome increases, the certificate becomes one of the things to be put on wall. Don't take me wrong, but at least let's start doing. Then these are the other objectives, and the critical challenge comes up on strategic objective number 3, HR. HR is not only in terms of having those many numbers, having the requisite skill, being sensitive towards the patient safety issues. If somebody is working in, say, OT, somebody is working in the ward, Of course, the pediatric ward ICUs are important, but patient safety event may take place even in the general ward, even in the medical ward. We all know that delayed hemorrhages. We all know the clinical definitions of the, say, sepsis, clinical definitions of the fever taking place. But are our front level functionaries who are responsible for day-to-day taking care of the patients, whether in the medical ward or the surgery ward or the pediatric ward, are sensitive to this need? I mean, the first and foremost important thing comes to my mind is being sensitive, being able to recognize that these are the things which, may happen. Then, we have also said that, we have also strengthened, particularly on the drug reaction, that what can be done. For the vaccination events, we have got AFI, NQAS for the AFI surveillance program, and repository of the good practices. Very honestly, yesterday I thought that what should I put? I will say I thought that let me put it to start upfront. Frankly, we have not yet created any repository. I am talking about NHSRC, not all alone, but as a country, as a health system person. These are the certain challenges which are there. Of course, the resources is a challenge. We are then shortcomings, our basics of the hand washing, the waste disposal, not only the biomedical waste, even the general waste, even the basic segregation practices in terms of the biodegradable or non-biodegradable. We all can look around in our houses or in our colonies or wherever we are staying, that where do we stand. Quality of the drugs at times becomes a concern, and though now recently, in fact, those of you who have been following it up, about 3 weeks back, after certain untoward things happening at the international level, DCGI has come down very heavily. They are creating a map and doing the stock taking, that who all are my manufacturer, what is the export, what is the quality, and the system is being put in place. But again, I'm only afraid that this approach should not become a reactive, because of certain, say, cough syrups, we all know, will not go into those details. In fact, to my mind, somewhere now I realize that point number 4 should have come on the point number 1. How do we bring about the quality and the safety culture? You see all around in your life, starting from your driving, lighting within the corridors of your societies, colonies, floors being slippery. To give an instance, like today morning, all of us walked for the beautiful photograph, hoping so, and with a lot of cheese. But the floors were still getting mopped, and I was keeping my fingers crossed that in the patient safety event, nobody should fall. Okay. So, professionals, chalta hai attitude. How do we change? And somewhere, very aptly, WHO has chosen this year, Patient Safety Day theme, that unless we empower our patient, our communities, and as a service provider, we also get into the habit of listening to them, involving them. It is no longer that traditional relationship between, say, somebody provider and somebody taker. That basic relationship has to change. And so these are, say, from the health system point of view, couple of the points which came to my mind, I thought of sharing with you. And once again, thank you very much for all of you. I'm really delighted with your presence and look forward to fruitful interaction. Thank you.
Thank you so much, sir, for your valuable thoughts. Our next speaker is Dr. Indu Arneja, Founder Director, Indian Institute of Healthcare Communication. Dr. Arneja serves as a core group member for Advisory Board on Health and Mental Health for National Health Human Rights Commission. She has conducted over 2,000 training programs, over 100 hand-on training workshops focusing on clinical communication. Awarded by a prestigious scholarship from the Academy of Communication in Healthcare, USA in 2021. Ma'am, now I invite you for your session, Patient Communication, an integral part of safety healthcare. Over to you, ma'am.
Thank you so much for the opportunity to speak on this topic. I think communication is usually a neglected topic, but to have kept it on the top, I think you know the importance of communication. So friends, honestly, I would like to share a couple of studies with you to start with that will at least open our mind to the idea, what do our patients feel? So according to a recent survey done in India by ICCCR MMA and Taragini, 45% of the families reported feeling unempowered in the treatment of their patient. They expressed inadequate clarity of diagnosis. They reported rushed consultation, perceived lack of involvement in deciding the treatment, and lack of clarity on treatment and care options. I'm sure those of you who have been patients sometimes, you will resonate with these findings. At the same time, this study says almost 1/3 of the patients and their family members indicated that they were not allowed to talk about their condition and symptoms. I'm sure some of you will tell me that we have just 1, 2, or 3 minutes. Where do we listen to the patient? Of course, this also needs to be addressed. Almost the same number indicated that the doctor did not straightforwardly address their questions and doubts. Probably we are not in habit of answering those questions because we come from the era where medicine actually was considered more like a paternalistic side of medicine, where we decided what is best for my patient, and patient had no questions, and patient had no right to ask the question. I think these details bring us to a point where we need to understand that the patient's needs for communication has changed, and how that is going to actually implicate patient safety, I'm going to share with you in a while. So patients today want to know about their illness. They want to understand the options available to treat their disease condition. They want to discuss the options and choose the one that benefits them. And they also want to be informed about the risks and disadvantages of the treatment. That means they want to partner with us. I think WHO has picked up a very relevant topic by saying patient engagement for patient safety. There cannot be a better person than patient himself or herself who could actually advocate for oneself. So it's time that we start taking them as partner and also engaging them. So let's have a look at some of these studies that would help us understand why engaging the patient is important and how that can help us actually improve our patient safety drive. This is one case I'm sure you all must have read in newspaper. I've changed the name of the patient for the purpose of confidentiality. But this patient was admitted to one of the state-run trauma center in Indian capital, where he had gone after a car accident for some stitches and some surgeries. He was mistaken for another patient, and he was put on surgery for a fracture that he had not attained. It's only after the incision was given, they realized that this is not the patient that needed to be operated. Another case, a 30-year-old woman, again, I'm sure you must have read this in paper. She underwent a wrong procedure. Actually, she underwent arteriovenous shunt for dialysis, whereas actually she had gone for simple minor pain abdomen. Third case, this was shared with me by one of the nurses for whom I had gone to do a training. She said a patient came and I asked her, "Are you Geeta?" She said, "Yes." I said, "Are you bitten by a dog?" She said, "Yes." I gave her anti-rabies, and then later on we realized she was neither Geeta nor she had been bitten by the dog. I'm sure you must have seen these kind of errors day in, day out in your setup. This must be nothing new. Another situation or a case that was shared by interns with me, since I'm teaching at Maulana Azad Medical College. So one of the interns shared that I went to take a patient's blood sample. I collected the sample. Next day reports came. It was put in the patient's case sheet. During round, when we were discussing about that case, patient said, my blood samples were never collected. Everybody was surprised, how could that be possible? The reports are already in the case sheet, and how is the patient saying that the blood sample was not collected? After a little bit of investigation, they got to realize patient number 6 patient number from bed number 6 was sitting on bed number 7, and his sample was collected as patient number 7. I'm sure, again, these kind of errors you must be coming across day in, day out. I think these are a couple of examples where the patient's identity could be confirmed just by communicating with the patient. Of course, we talk about 2 systems and 3 systems. Just asking, are you this, what is your name, even that could have been, probably that is one of the basic communication we need to have with the patient to ensure patient safety. So patient communication is an integral part of safety in healthcare. If I talk about diagnostic error that Dr. Srivastava was talking about, almost 40% of the errors are around diagnostic error. And one of the major reasons is we do not allow the patient to narrate their story. Some of us complain if we allow the patient to talk, they will take longer. So therefore, it is better to ask them some leading questions, some closed-ended question, and then assume what could be the reason for the patient's visit and treat them. We usually complain that they would talk a lot, but studies suggest that a patient can talk about their problem, most of the patients can talk about their problem in 60 to 80 seconds. And if you allow them to talk, you will actually be able to make almost 50 to 80% of the diagnosis. Studies have shown that if you ask open-ended question and you allow your patient to talk about their problem and you listen to them attentively, most of the diagnostic errors can be prevented and you can be very close to the accurate diagnosis. This is another case that I want to share with you. Patient Neeraj, 21 years old male, he underwent removal of calcified tumor at the junction of third and fourth rib by a cardiothoracic surgeon. So the cases that I'm sharing with you, they're all real life cases. I've not cooked them. They're all real life cases. So this patient, he complained of numbness below the nipple area. Since the surgeon who had operated had left for the day, he asked his team to send a referral for a neurologist on urgent basis. I'm sure something like this also you must be seeing day in, day out. What was the outcome? The seriousness of the situation was lost in the transit of information, and no one took patient's complaints seriously. The neurologist came to see the patient only, 1 second, is this me who's doing it? Sorry, I'm so sorry. Yeah, so the neurologist came to see the patient almost after 16 hours. By then, the patient had actually gone into irreversible paraplegia. The hospital had to compensate to the patient. Of course, monetary compensation can be done to maybe relieve the suffering, but you can well imagine a life of 21 years old boy, what would have been, it would have been after paraplegia. I'm sure many of you may be having children of the same age or your siblings of the same age, so you can well imagine how torturous it must have been for the family. Another real-life case in a government hospital, gynae ward, a young lady delivered normal, healthy child, was moved to the ward. Later, during the day, she felt that she was bleeding more than normal. She asked her mother-in-law to go and, report it to the doctor or the nurse, whoever was there, on duty. The mother-in-law went once, twice, and thrice. Unfortunately, nobody came to see her. By the time they realized, she had already gone into PPH and we lost that mother. I think it's time that we start taking our patients' complaints seriously. Trust me, almost 80% of the patient complaints are very genuine and they need immediate attention. Problem is sometimes we take it very lightly and as a result, they go into fatal conditions. So number of fatal lapses could be prevented if we promptly handled patients' complaints. And not attending to the complaints, we all know it creates a lot of dissatisfaction and agitation in the patient's and family's mind. That itself becomes a reason for violence against us when things go out of hand. So I would say a couple of tips that will really help us in effectively communicating with the patient and their family member. I'm sure you all must be knowing it, but I'm just repeating it for everybody's interest and probably revisiting it, that please, when the patient talks, allow them to speak and listen to their story, because you'll have a lot of information that will make a lot of sense in making right diagnosis. Practice attentive listening. A lot of time when the patient is talking, we are multitasking or we are mentally somewhere else. As a result, we not only miss a lot of information, but that also communicates to the patient, what you're talking is not making sense to me and is not very important to me. When patients and their family members come up with some complaint or some request, please take it seriously. That will help us in making sure that no patient suffers harm because of our negligence. At the same time, when you're going to do any procedure, please confirm and double ensure to check the identity of patient before doing any procedure. Let's have a look at another case. Patient Kaushalya, 65 years old. She underwent cardiac surgery, bypass surgery. The surgery was excellent, recovery was good. Then she came for regular follow-up and she was doing very well. She was managing her medicines. In between, she moved to another place, and in between, she stopped taking this medicine that was prescribed to her, and that is antiplatelet medication. She didn't realize that it's important to continue. I know on what reason she stopped. After a while, she started, complaining of slurring of voice and some weakness in left or right part of the body. She visited her nearby hospital or doctor, who probably did not understand the, situation, prescribed some medicine. After a week or so, she was found, lying outside bathroom. She had stroke and she was on bed for 3 months, and then she passed away. I'm sure some of you must be thinking, it's patient's fault. She stopped the medicine, it's completely her fault. Can we look into it that could I have made it very, very clear to the patient that there are certain medicines that need to be taken, continuously, and only after consulting the treating doctor you have to stop that. Of course, I'm sure medication safety is going to be covered in detail by ma'am, and I'm not going to venture into it, but just to reiterate that please, when you're talking to your patients about their medicines, make sure that you explain them do's and don'ts, especially certain life-saving drugs which need to be taken on continuous basis or should not be stopped, or should be stopped because it can have its own harm, should be communicated in a very, very clear manner to the patient. Make sure that you inform the patients about the side effects. A lot of time we are apprehensive. If we talk about side effects, patients will have more questions. Please do not hesitate discussing the possible side effects, but it's important to let them know that there is a possibility of side effect, and if that happens, what is the next action they are supposed to take. Explain both in verbal and written form. A lot of time we explain things verbally. Trust me, we forget 80% of what we listen within 24 hours. You can try it for yourself. You will get to see we actually tend to forget. So we need to communicate both verbally and in written form so that it stays with the patient for a longer. And then, of course, teach back. If we could use this tool on regular basis with our patients and with our healthcare professionals, most of the errors can be prevented. In teach back, see, when you explain something to the patient will be nodding. And when they nod, we think they are listening and they are understanding. Ask them, have you understood? They'll say, yes, ma'am. Yes, sir. Okay, can you tell me in your words what have you understood? You will get to realize they will not be able to repeat 30 to 40% with accuracy. Rest, it will be all confusion and not very clear. So I'm showing you this slide. I don't know if this will really move the way I wanted it to move because it's in a PDF form. But this is a slide I want to show you quickly, and I want to ask you, how much of it did you understand? Could anybody understand? Exactly what? Oh, you could understand. Thank you. What about others? Nothing. Because it's something like medical jargon for the patient. So when you explain to your patients about their treatment, their diagnosis, prognosis, intervention, trust me, 50% of the patients and their family members do not understand much. We know medical information as it is very complex. Over and above that, if you are using medical jargon, it makes it further complex and difficult to understand. As a result, it reduces patients' engagement. They may not understand, but they still will be nodding because they don't want to be seen as not intelligent. So they would be nodding to show, yes, 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 I understand, but actually they would not understand much. We know, how many languages do we have in our country? Any idea? 22? And how many how many dialects? More than 700, yeah, more than 700. So there's a saying, kos pe pani badle, char kos pe bani. Sorry, I'm saying in Hindi. The exact meaning is that after every mile, you can say, the taste of water changes, and after every 4 to 5 miles, there's a change in the language. So linguistic barriers are actually too large to understand. So we really need to make sure that whatever we say, patient has actually understood. So if you did a small talk with the patient before you actually ventured into the real case, you will get to know what language your patient speaks, what language your patient understands, how much do they really understand. Check their health literacy. That will also give you an idea in their ability to understand what you're going to share with them. So when you're communicating with your patient about their treatment, please make sure that if there is a language barrier, make sure that you address it promptly. Use simple and clear language at all times so that your patients can understand what are you saying. Use audio-visual aids. I think this is one way to actually reduce the barrier, because when the patient can see or hear and do it, they will understand it better. If you have models, charts, or maybe nothing, draw on a piece of paper and explain them their diagnosis, their treatment, or their progression of disease, or the procedure that you are going to do, it will make more sense to them. Please explain do's and don'ts clearly, and also check for understanding. As I said earlier also, they'll keep nodding, but you really need to confirm whether they understand. Documentation error, that's also part of patient communication. That's a very vast area. I'm not going to touch on anything, but I think patient's OPD slip is one communication that happens between you and your patient. These are a couple of samples I'm showing you to just help you see how we communicate. So when next time you're writing your document for the patient, please keep your patient in mind. Can my patient read what I have written? Can my patient understand what I have written? Because a lot of errors happen just because of misunderstanding or misreading. There was this saying, doctor's handwriting can only be understood by a pharmacist. Probably that's not possible now. Even the pharmacists sometimes don't understand the language. So coming to the last point that I want to make here is communication challenges of vulnerable patients. I think this is one area which remains neglected because we think patient who is unconscious or is critically unwell, what communication needs can this patient have? They all have needs. Everybody has communication needs. If I ask you to stay quiet and not talk for 5 minutes, you'll feel suffocated because everybody wants to talk or say something. So patients like pediatric patients, psychiatric patients, geriatric patients, or patients who are not oriented or hard of hearing, visually challenged, you will see these patients, we don't make much effort to connect with them. We really need to be proactive in finding ways how can we communicate with these patients and make that communication channel open with them so that they can also communicate their concern or whatever information they have to share with us, they can do it. There are a lot of ways to do it, and I wish we had time, we could have talked at length about it. But even if you had some sign, chart or some poster or some, copy or a pen that you could give to your patient, I'm sure patient will be able to communicate with you. So, as I said earlier also, there cannot be a better person to safeguard their interest than the patient themselves. I think we really need to take patient engagement seriously. It's not difficult, it's not rocket science, it's only the desire to share the information with the patient. I was talking to Ratna Devi a minute ago and I said, one of the biggest hesitation in empowering the patient is if my patient knows what is right, they can point out my wrong. I think if I can overcome this fear, I can make my patient more, self-reliant and empower them with the right information. So the benefits of effective communication is patient will get engaged, there will be improved compliance, definitely outcome will improve, medical errors will go down. As a result, patient safety and continuity of care will be looked after. This is one of the message for all of us from a patient. They did everything to me, but nobody communicated with me. Thank you.
Thank you so much, ma'am, for enriching the audience with your knowledge. For the next session, I would like to invite Dr. Sangeeta Sharma, Professor and Head, Department of Neuropsychopharmacology, Institute of Human Behavior and Allied Sciences. Ma'am is a pharmacologist, quality manager, and has an MBA in Healthcare Administration. She is also the Honorary President of Delhi Society for Promotion of Rational Use of Drugs, which is an NGO working in the forefront of promoting rational use of medicines and improving accessibility and availability of quality drugs since 1996. She has also conducted more than 200 capacity building sessions for doctors, nurses, and pharmacists. One of her pioneering work is Standard Treatment Guidelines, a manual for medical therapeutics. Ma'am, over to you.
Thank you. Thank you for your kind introduction, and thank you, Dr. Srivastav and NHSRC Deepika for giving me this opportunity to come and talk to you, all the luminary people who are working in quality at ground level. I know many of the things, which we say here are easier said than done, but you are the real, people working on ground, facing these challenges on day-to-day basis. And I think my job has already been made easier by Dr. Srivastava by giving the global picture as well as the national picture, the impact of it, the numbers, the magnitude of it, and further Indu made my job very much easier because, treating patients is not simple. It is not, one-to-one mathematics that we do. It's really a complex system. There are several people involved in the care of the patient, and some studies have even estimated that there are more than 100 people contacts for one inpatient in the hospital. So you can imagine if there are communication gaps in that process, what can happen to the patient. But I believe yes, we are all human beings, we are fallible, we make mistakes, but rarely it is due to mistake of one person. It is the series of people who make the mistake, and that's how it reaches the patient. So that's where I think the medication management comes in, because most of the time medications are important. More than 60% of the patients we deal with are treated with medicines. So that's how the harm caused by medication becomes a very important. As such, you all must have recognized the prescribing is a very complex task. It requires diagnostic skills, it requires knowledge of medicines, it requires an understanding of principles of clinical pharmacology, which remains a theory for most of us. We just pass out, cram up something, and purging karte hain exam ke baad, and then we forget. But there is a great need of applying this pharmacology knowledge when we are treating our patients. Communication skills, of course, and then appreciation of risks and uncertainty. That is very important because patients, sometimes we find that suddenly they are deteriorating. Even despite taking all the care for the patient, you find that they are not responding or they deteriorate. So that kind of atypical response to medicines is there. Some genetic predispositions, hypersensitivity, all these things lead to uncertainty. But rational prescribing is something that can safeguard most of these problems, if we are following. But on the contrary, current prescribing practices are far from rational. It is more of a past practice that I had been doing this for last 15, 20 years. I have seen thousands of patients and I have treated, and my patients have got well also. How can you tell me that my prescribing practice was not rational? Maybe today in this era of litigations, we have resorted to defensive practice. We don't want to leave out anything, for the patient that tomorrow they may complain to this, like that, but, are they evidence-based? That's the important question that we need to keep asking ourselves. As many people say, there is always a gap between evidence and the clinical practice. I did a survey of about 400 participants, and I asked them two questions. Is there any gap in clinical practice? Most of them said yes. Then after 2-3 questions, there was another question: do you need to change the way we practice? Then most of them said no. That was the dichotomy that we have, and that's what the situation is like. And there is a global epidemic of irrational drug use, and we are most worried about the misuse of antibiotics and overuse of injections. We all know antibiotic overuse can lead to AMR. we are already actually into a silent pandemic, AMR pandemic. It has already reached us. We have already entered into post-antibiotic era, where the existing antibiotics are not helping the patient. We are losing patients because of these infections in our ICU. We do very good surgery, as she gave the examples, complex, microscopic, everything we do for the patient, but we are losing them to infections. So one take-home message here is that we need to look at this, how are we using our antibiotics here? Extravagance is there when we can treat patients with cheaper medicines, cheaper but effective. Most of us have this notion, anything which is cheap is not good quality, which is wrong. Essential drugs, the generic drug could be of good quality as well. So we need to think about it. Over-reliance on medicines. We are not spending any time with the patient to explain their symptoms or review their follow-up and all that, but we just go and keep on adding a pill for the patient. And further, this is continuing because we are not selecting our medicines properly. Standard treatment guidelines are either not developed, or even if you have, they are not followed. Many of you may say, yes, we do have standard treatment guidelines on our desk, but let me ask you, put your hand on your heart and say how many of you have ever opened that and referred and tried to apply this. And then rampant use of branded, fixed dose, irrational combinations. If you go and do the prescription audit, you will find for diarrhea patients, typical stereotype prescription will be there. There will be a ciprofloxacin, there will be a tinidazole, and there will be 1 packet of ORS. 1 packet of ORS. And rarely we know this is caused by mixed infections. Most of the time it is viral, where ciprofloxacin is not going to work. But still this is continuing. So when I believe most of you are doing prescription audit, but do look at this aspect as well. Just don't do it for the numbers, because for the NQAS assessor that you have to show that you've been doing audit, but look at what is the actual quality of the prescribing here. So cost is also huge. I need not go into the detail. When it comes to primary management, medication management, we are talking about medication therapy, improved outcomes, minimizing the risks. Prescription issues are there. There are labeling, packaging, naming issues at the country level. So we are working on that. Also, we have given recommendations to the government to take care of this naming problem, because one brand name is given to several, drugs, because there is no such policy here. So this can lead to a great mix-up, and you can imagine a patient who was to receive pantoprazole receives midazolam just because the brand name midazolam was the same for the two. There are many such examples, and there are one-letter differences in the brand name. Please be very, very, very careful about this. When this NMC regulation came, everybody was up and criticizing it, but nobody talked about brand names with one-letter difference and giving rise to errors. Domstal O, Domstal OD, Domstal RD. Just one letter difference and the entire different composition would be there. So be aware of that. And then, as I always say, medicines are double-edged swords. If you have effects, you will have side effects too. But it is the art of the prescriber with which he can or she can reduce the harm caused by medicines. While adverse drug reactions are inevitable, but certainly I believe you can reduce it by timely identification. Medication errors are totally preventable. Nobody should be supposed to be suffering from error because of the mistake done by any one of us in when we are delivering care. So be careful about this. The impact is huge. We know the medicines save life, improve quality of life, but at the same time they can be dangerous too because of the adverse drug reaction, drug interactions, medication errors, and so they can add to mortality, morbidity, waste of resources. Also, unnecessarily we are giving these medicines and wasting our scarce resources on these irrational practices. And then last one, this one, psychosocial impacts. This is very important. I don't, Indu, you didn't touch on that maybe because of the paucity of time. Patient demand. Many of the things, irrationalities or the practices which we support are on the pretext that the patients demand for it. And I ask this question all the time, is it the real demand or a perceived demand? For diarrhea, we have given medicines for 4 decades, 5 decades. Dependal बहुत दिया जाता था पहले, अभी वो वाला brand इतना नहीं available है. That was a metronidazole anti-amoebic. So people started depending on it. Every time what you write, people take it seriously. And they ask for these medicines because next time if you don't say, you just say you need to take ORS, they will not believe you. Because by our own behavior, our own prescription has taught them that there is a pill for every ill. So only non-drug treatment, non-pharmacological treatment is not acceptable to them. So, and this demand will take some time to go. So we need to be patient about it. So, as a safety measure, we need to do medication reviews. We need to, we are very, very good at stepping up therapy. No response? Okay, add another drug. Yet no response, add another drug. So that leads to prescribing cascade, and that leads to polypharmacy, but we never step down. We never review the patient. Is there a continued need for all these medicines, or can some of these be weaned off, removed, deleted, or reduced in dose? So keep looking at this. That is very, very important. As I said, polypharmacy is the biggest risk factor. More than 6 drugs in a prescription, expect some ADR, some drug interaction, some error to happen, either from your side or from the patient's side. Some error will happen. So de-prescribing is something that we need to learn, this art of de-prescribing. I don't have to teach anyone the prescribing part of it, I think, but what is more important is the de-prescribing part of it, that you scale down, de-escalate, step down the treatment. And prescribing cascade, I think most of, if you go and see, very easily you can reduce 1 or 2 or 3 medicines from the big list. Today morning only, I was having a session. We were discussing, who are the people who are more prone to this, prescribing cascade? Those who are insured, CGHS beneficiaries. I have seen up to 25 drugs in a prescription. You can imagine what was happening to the patient. Then, of course, standard, guidance, guidelines, tools. These are time-tested tools which can promote rational use of drugs. These need to be adopted at the clinical level. वो दिखाने के लिए SSR के लिए नहीं मत रखिए. That's one part of it. आपको 2 नंबर मिल जाते हैं उस पे. But important part is whether people are referring to these guidelines or not, So then medication safety, I think we have nursing colleagues here also. They need to look at, that all rights are followed. With medicine, it is not only the medicine, drug, dose, strength, duration, which has to be right. Even rate of administration has to be right. One example which I always give is potassium chloride. If you give this drug as a bolus, it can be disastrous. It can lead to immediate death of the patient. So even the rate has to be, so you have to give importance to this detail of medicine as well. And of course, drug use in pregnancy, we need to be very cautious about this, which are the safe drugs, which cannot be given, because there can be serious adverse events associated with it. You know, high alert medicines, the UNQUAS checklist, Kushal, this thing also has that, all the components in place. We need to control this. Potassium chloride, why should it be available in IPD? It is needed only in ICU setting or OT setting. Drugs like vicuronium, why should it be available in IPD? So you can control the distribution and avoid certain errors. Similarly, you can use auxiliary labeling to identify these high alert drugs. Auxiliary labeling could be one simple instruction like shake well before use. We don't give importance to just these small little instructions, but if it is a suspension and of a high alert drug, phenytoin. I keep seeing these patients every day in my lab for drug levels. When they are taking the supernatant, they have breakthrough seizures because the drug concentration is low. When they take the precipitant at the bottom of the bottle, they come with the toxicity. Both are avoidable if we give simple instruction, shake well before. You can use auxiliary labeling for this. These days there is no dearth of budget on these activities. Those containers, organizers are also available. We can easily use these. And the key area of medication safety challenge is, when you see patients in emergency, ICU, of course, in high risk setting, very small patient, very elderly patient, be careful about these settings, and whenever you're using these high alert drugs. Polypharmacy, I said, but also be careful about, at the time of transition of care. When the patient is moving from one patient care area to another, this is the time when most errors happen, because many a times you will find a duplication has happened, or omission of an important medicines. She gave you the example, the most important medicine which was to be taken was omitted because nobody explained. Documentation, particularly when it comes to medication management, be careful. Document this allergy information at a uniform place in the medical case record of the patient. Patient identifier should be there. Many a times you will find patients saying, हाँ एलर्जी तो थी, पिछली बार अस्पताल गया था, कोई रिएक्शन हुआ था, कोई दवाई तो से हुआ था, अब कौन सी दवाई से हुआ था? They don't know. So ideally they should be given a card, but chalo nahi diya aapne. So I think technology comes to your rescue. We all have a phone with us, smartphones, even patients are carrying. So you can always give that in writing. They can take a picture and tell the patient that every time you visit a doctor and a prescription is written for you, must show this history of allergy so that these can be avoided in future. Unsafe injection practices, I don't know, you can see these are still, you will find, आप कहोगे कहाँ से ले आई पिक्चर, आज के ज़माने में नहीं होती है, आज के ज़माने में भी होती है. Reconciliation is another review, assessment, reconciliation. You will pick up this duplication, omissions, because patients are taking treatment from various providers. Patients also sometimes have these notions, I'm going to X doctor, I must show him this prescription only. If he's visiting A, B, C, D, others, they will not talk to you about it. So it is for you to elicit that history, find out what are the other medicines that the patient is taking. And many of us have this notion, herbal medicines, Ayurveda medicine, homeopathic medicine, they don't have any drug interaction. They also do have drug interactions. So look into this aspect and exercise caution during multidisciplinary care provision. communication becomes very important here. Chronic disease management is something that we need to be very careful. We need to standardize care. This is where many of the things will go wrong. Omissions, deviations, clopidogrel was discontinued because we never prepared the patient that this is the most essential medicine for this. So hypertension, diabetes, these are also, the burden is also increasing, so we can't shut our eyes regarding this. Monitoring, early recognition of these ADR or deterioration is very important, and we need to be prepared with a targeted response, timely. Many of the renal, suddenly you'll find a young patient lands up with you in a end-stage renal problem. Very often you will find it was the treatment given was responsible because we failed to identify the drugs causing acute kidney injury. So the immediate treatment is that you identify, stop these drugs, and the patient will recover from these. So, and then otherwise we will be having to look at the rehabilitation of these patients. And of course the patient-centered care is today morning they were saying that we have 10 drugs are most commonly dispensed from the pharmacy. So we have that stamp, and for whatever drug is required we tick that. Is that acceptable? Please think about it. So for our ease, we adopt, so the solution should not be worse than the original problem. Collaborative care, must talk to others, because very often these patients need collaborative, they must need to consult other physicians, other specialists, so we must be, refer kar diya, that's not the problem. What for have you referred, whether the proper treatment has been given or not, that has to be also optimized to, and reporting, I think Dr. Srivastava has already mentioned, patients, anyone in the healthcare system, doctor, nurse, pharmacist, even nowadays patients are being encouraged to report. Of course, the reporting done by patient would be different from what you report. You would be reporting more of the adverse drug reactions, the typical medical terms, but patients here report about the quality of life. I feel fatigued, मेरे को बहुत weakness है, which we don't recognize even, when our patient comes, it's a psychological problem hai, saying all these things. So a reporting system has to be established, patient education and counseling has to be done. Without that, the treatment will remain incomplete. It is the patient who has to take the medicines, and if we don't prepare them, at least naam nahi yaad karega, so you can tell them purpose of the medicine. That this is for fever, this is for infection, this is for diabetes, this is for BP. And many of the patients believe that my BP is controlled with antihypertensive now, I need not take this medicine. So you need to emphasize here, it is with the medicines that his blood pressure is controlled, so he needs to continue taking these medicines. Similarly for diabetes. So you need to prepare public education material depending on your problem, the type of patient you see in your health facility, because the experience, you may have arranged a particular system for the patient. The experience of the patient may be entirely different. There may be opposite views here, so unless you talk to them, you take their feedback, you involve them in delivery of care or improving care, whatever you are doing, you need to involve these patients in this and take their perspective and improve. And I think, I don't know, you can see, I think Indu, touched upon it in the first slide itself, we don't allow patients to talk. So we need to empower them. Communication is a key. Patients may be having a hearing problem, visual problems, so we have to look at the special needs of the population and address accordingly. Then adherence promotion, you can use materials, not that everything has to be done by you yourself only. You need to delegate these tasks to other team members in the hospital. एक जगह मैंने बोला कि BP लेना है सब patient का 40 years and above, every visit you should take a BP. Standard of care says BP should be measured. They said ना डॉक्टर के पास तो टाइम नहीं है, BP लेगा. तो मैंने कहा अच्छा नर्स को बोल दो, नर्स गलत ले लेगी. What is it? See, delegation of tasks is also important, and it is a teamwork. Use gadgets, things, review with medication, take these electronic health records. Those are who have HMIS, CPOE systems must use it. This help in storing the patient's information at one place. These should be leveraged. NAML, standard treatment guidelines. ICMR has come up, NHSRC has developed, you can visit the website, you have 12 STGs given there. They were prepared with a very long drawn process of consultation. So it is teamwork, definitely. We need to ensure optimal patient care, and as a healthcare profession, stay updated, assess patient profiles, communicate effectively, monitor closely. That will lead to medication safety, and we will be able to improve. For patient, last one thing, for patient, any adverse outcome, severity or a complication or a death, for them everything is medical negligence. So we need to really look into it, and all this can be done by having both systems in place and effectively communicating with the patients. Thank you.
Thank you so much, ma'am, for your valuable thoughts. Now I invite Dr. J.S. Arora, General Secretary, National Thalassemia Welfare Society. Dr. J.S. Arora is a member of WHO Advisory Group, Patients for Patient Safety Program, and President of Pahuja Trust of Blood Disorders. Sir has received a Lifetime Service Award from PHO Chambers of IAP, THE, NCPDP, Universal Design Awards in 2018. Sir has also recognized as Patients for Patient Safety Champion for India since 2007. I invite you, sir, for sharing your insight on patient empowerment for safety in healthcare. Over to you, sir.
First of all, I'd like to thank Dr. J.N. Srivastava, sir, Dr. Atul Kotwal, Dr. Deepika, and NHSRC for giving me an opportunity to present the topic for which is in the core of my heart, that is patient safety, with which I am involved since 2007. See, empowerment or engagements, these two are the two sides of same coin. There cannot be empowerment without engagement. Unless until you empower the patient, you can't engage the patient. And for engage the patient, you have to empower it. And for engagement, you need communication, as told by Dr. Indu. So empowerment is putting the data in the hands of patients and giving them control of their destiny. And engagement means that providers are not just giving patients their information and allowing them to speak to control the outcome, but rather the providers actively work to engage patients in their health care. It is not just giving information, it's giving them the chance to, after giving the information, to ask the things, to tell the things, to communicate what they have learned. If you are not giving the chance, you are not empowering them. So why empower? Because the patients and their attendants, they see the things differently than the healthcare providers, because they are the richest source of information related to medical errors, because they have lived with it and they have seen the system failure from beginning to the end. Patients are much more to offer than the healthcare providers, administrators, and policymakers. The voice of patients and families who have suffered preventable medical injury is the powerful motivation force. And this we have seen in the thalassemia as well. See, we have been talking to many persons to spread awareness on thalassemia. I'll be speaking more on giving examples more on thalassemia because I work on thalassemia. It is the patients and parents who are more dedicated, passionate to tell the public and their friends and relatives to go for thalassemia screening because they have suffered. The person who has suffered, he is more motivated than any other person just giving a lecture. Activated patient has a knowledge, skill, and confidence to self-manage their own health, be involved in treatment and diagnostic choices, and collaborate with the providers. Patient empowerment is a process by which patients gain more control over their health and health care. WHO defines empowerment is a patient's capacity for the better control their health and life, to assist other patients in improving their lives, and to assist healthcare professionals. They are not taking care of their own health. They also, when they are aware, when they are empowered, they also tell their peers, their other co-patients, how to treat those diseases, what precautions to be taken when they are having the similar conditions over there. Empowerment refers to a capacity that enables patients to participate and be involved in their own disease prevention and care. Educating, that the first and foremost thing is educating healthcare providers about patient engagement. Educating healthcare providers to involve patients both at the organization and individual level. It is not just at OPD level only. I think here comes the role of the hospitals or the government, where they should be involved in the management and the policy making. It includes patient engagement and safety in educational curriculum at undergraduate and postgraduate levels, developing a learning culture rather than a blaming culture. I think this is the most important thing. People don't report because of the fear of blaming, be it a doctor or a nurse, or even if a patient reports, he has feared, if at all he reports the error of the patient, doctor or nurse in between before the patient discharge, then his treatment will be hampered. So there should be some legislation, some procedure where the blaming should be converted into learning. Supporting patients to become actively involved, encouraging patients to report on safety incidents, near misses, and safety concerns, actively promoting patient feedback system, and giving feedbacks to follow up. Sometimes we can ask the patients, okay, what happened, you just a feedback. But if you don't follow them, if you don't take action on them, then taking feedback is useless. So there should be a process. Then when the patient gives any feedbacks, if you have a drop box over there where the patient can put up their complaints, there should be some remedy available to them as well. And bring legislation that supports patients and their families to engage in issues relevant for their safety. Legislation may be some tough word to say, but since we have already taken legislation for the informed consent in clinical trials, and even for having surgery, invasive medical procedures, we take consent from the patients. Same way, there should be some process, some legislation, some way that patient engagement should be made mandatory. Providing patient with appropriate, accurate, and up-to-date information about treatment and safety issues in a user-friendly and language format. Here I like to give an example. Suppose a patient, you are asking for a gallbladder surgery. You just don't say, with एक लैब कॉल होगा, ये ओपन सर्जरी होगी, ठीक हो गया तो ठीक है, नहीं तो ओपन करेंगे. That is not the process to communicate. You tell them why you are doing for lab call only, and where you have to go for open surgery. If at all you are going for lab call, how many days you have to stay. If you are going for open surgery, how much more you have to spend, how much more you have to stay. So these things should be told. Not just communicating, okay, we have told them, if at all it is not successful, we will go for the advanced surgery. How patients are involved? Exploring alternative ways, because nowadays it's a digital available everywhere. So it is not only face to face. You can communicate on telephone, WhatsApp, email, online, video call. As Dr. Sangeeta told that if at all the doctor is busy, the patient can send a message on WhatsApp and they can be informed on WhatsApp as well whenever the doctor is free to communicate. Putting in place system to facilitate patients' access to health records. This is again very important thing. We are facing very regularly about this. See, there are most of our patients are going to hospitals for blood transfusions. They come to us for consultation, for secondary consultation, for chelation, monitoring, etc. When for taking the medicine, we need monitoring. We need different blood tests for blood parameters. So what happens when we ask them to give the reports? डॉक्टर ने वहाँ कराया था लेकिन रिपोर्ट दी नहीं. हॉस्पिटल ने रिपोर्ट क्या करनी है? See, hospital should give the reports. And nowadays, even I have seen not only government, even private hospital refuse to give reports. This should be the right of the patient to take the reports, because without reports, nobody else can help you. Involving patient advocates to support the engagement of patients at the direct care, organization and policy level. As again Dr. Sangeeta said, sometimes, okay, you may take in the hospital the help of a nurses and pharmacists, etc. But that is not always possible. You take up the help of the people like us who are advocates for the patients, who are working for the patients, who are helping the patients. So there are many things can be taken care by their patient advocates. Supporting the work of patient-led voluntary associations. Again, I would like to give my example. Here, many times some patients come from hospitals to take this monitoring and sedation, etc. with us. And when we say prescribe something, and he goes back to that particular hospital, what happens? The doctor over there say, okay, you are going over there, आगे से blood भी वहीं चलाना. I don't know why they are offended. See, we are going to help them. After, we are not competing with them. We are not contradicting them. We are just to help them, because we understand they are busy over there. But what reward we get it? If you are going to for them for chelation, don't come to us. Take blood from them also. So this is happening. Campaign raising public awareness about needs and benefits from the strengthened engagement of patient family members in patients' safety and primary care. Adopting engagement strategies to local, social and cultural context. That is also very important. If anything is socially taboo, so you should discuss with a decent way, in a moderate way. It should not be hurting to that particular person because that is not acceptable in their social circle. Create services in partnership with patient and parent organizations. Engaging patient organizations at the earliest stages of service design, development and evaluation. Here I like to say, whenever your government is drafting for policy, guidelines or anything else here, they should involve this patient advocates or patient organization. I have seen in many places they have involved, but they out of say 30-40 people, they have invited one person. So after 41%, what his voice will be not heard. If at all he has said one or two things, nobody is going to listen. So there should be some respectable representation of the patient organization or patient advocates. Gather feedback on experiences of care, complaints and outcomes to make improvements. Work with patient participation groups and carers as partners. Their experience and expertise makes services better tailored and sustainable. I have no hesitation to say the experience of our patients or our organizations may be much more than the doctors who have been working for the 10 years in the same department. And they should be acceptable to the government or you can say organization or the hospital authorities. People are not just experts in their own lives, conditions and care needs, they also hold vital knowledge about local services. Sometimes we say, okay, you go for this particular test. That test may not be available over there. Suppose and we do MRI T2 star. That is available only in 4 or 5 cities in the Delhi, so India. So we can't ask a patient from Moradabad or Bihar to go for that. So either we should arrange the facilities and we not just advise them. Their knowledge drive improvement makes services responsible to needs. Providing sportive environment, encourage and facilitate interaction among healthcare professionals and engagement with patient families. Promote open disclosure about safety incidents to patients. Linking patient feedback system to organizational system for learning and improvement. This again, I may be repetitive, but it is very important. Providing information and support for self-care such as counseling, peer support groups and coaching. Designing and supporting patient safety champions or advocates to help facilitate patient engagement. Setting up mechanism for patient engagement at the system level. So system has to change. It is not the only at the ground. See, okay, I understand that 90% is care taken by the primary level. That's the most important thing where patient and doctor are face to face. But until the system changes, the upper layer change, you can't have effect in the lower change as well. So President John F. Kennedy in 1962 set out the rights of consumers, right to be informed, right to be heard, right to choose and right to safety. Though he said for the consumer protection, but these are the same vision that applies to well to the patient empowerment, engagement and patient safety. Healthcare worker support is crucial to enhance patient participation in error prevention. It implies the acceptance of patient participation and need to encourage patient contribution and be receptive to their inputs. A major education campaign is required to convince doctors and nurses of the value of patient participation. I think I missed morning session, some poster and video has been released. I'm not aware of that. But what I think is there must be some poster which should be placed in every clinic, every health setup, that patient engagement is must. Maybe 2-3 points should be written over there, so the doctor is forced to engage the patient, because when it is written in your clinic, then you have to abide by. So if it is like that, fine, otherwise some changes may be there. After securing professional support, patient education programs will be needed to build understanding of their contribution, legitimacy and relevance. So first educate healthcare professionals and then followed by the patient education campaign. Yes, patient also has a role to play. Patient should think that he should be involved in routine monitoring and reporting of adverse events. Check and double check that they are given the correct medication in the correct dose and the correct time. As Dr. Sangeeta said, patient may not be aware of what the drug is, but even by looking at the basic spellings, something can be noticed. I give you example of recent COVID pandemic. See, I prescribed one patient SpO2 monitoring, which was a must for the all COVID positive cases, that is peripheral oxygen saturation monitoring. What the chemist did, chemist gave the patient O2, which is Oflox plus Ondazole tablet twice a day. I said, a patient came to me after taking 3 days. I said, why you are taking this? He said, that too he came because he developed vomiting. He said, I am getting vomiting, and that's why he came to me after 3-4 days. Then I called the chemist over there in the front of the patient. I said, how you interpret it is this Oflox Ondazole combination. He said, you write SpO2, means syrup O2. Okay? Okay. Then, and since the patient is adult, so I converted syrup into tablet. Then I said, okay, okay, I am wrong. SpO2 is wrong. Instead of syrup or Ondazole Oflox, you interpret it as tablet. But where is the word monitoring? I said SpO2 monitoring. What you interpret for monitoring? Then he said, oh, I said twice a day देते हैं तो मैंने भी दे दिया सुबह शाम खा लो. So this is a real case happened in this COVID pandemic with me. So patients should be informed what to expect in terms of surgery and be encouraged to report any adverse events or complications. Here I would like to say in bone marrow transplantation, what we see it, one way the sibling transplant, the results are very good. Okay, with undated transplant, bit less. But around 2-3 years back, there was one institute who are going about haplotransplant, that is half match transplant. And patients were not told that what is the prognosis and what is the outcome of that transplant. So patients were expecting, okay, if it is sibling 90, 95%, 80% so, while with that is 50%. And you imagine 22 of the 30 transplants failed and patient died. Had the patient been informed, and that too about one center, one city only. Had the patient informed that with the half-match transplant and the success is just 50%, I think 90% patients have not gone for the haplotransplant. Observe and ask staff about hand washing practices, which is very difficult. You can't ask the patient staff. Ensure they have been properly identified prior to treatment. Patient involvement in safe blood transfusion. Question the appropriation of an intervention. Ask about risk, benefits and alternatives. Here I'll again give an example, live example, that many of our patients, young patients and infants and early child, 1 year, 2 year, 3 months, 6 months, if a doctor sees a child with a hemoglobin level of 7 grams, he advises okay blood transfusion. And without diagnosis, what is the actual cause of anemia? And later on that turns out to be thalassemia major. And once you give transfusion, it is impossible to diagnose by HPLC, which is the easiest method. Then you have to rely either on the patient's parents' HPLC or mutation analysis. And many times we are always in dilemma, at least first 1-2 years, whether we should give blood or not blood. So we will giving blood is not an easy way. They should think twice before giving blood. And ensure their identity is properly checked. That is again very important. And we have seen our many thalassemics that being giving wrong blood, but they have been near miss. The patient are aware and they check whether their name and blood group is there. Ask questions about what they can and cannot do, what to expect. Ensure means when they are on the blood transfusion, what they can do, what they cannot do. And again, sir, I like to again one more example, very recent, maybe month or so. A patient sent me a video of blood transfusion. She was being transfused, and the rate of transfusion, blood transfusion was 92 drops per minute. And it is almost 3 times, but I understand. And I sent, because I didn't want to hurt the doctor, because everybody is quite known to me. I just sent the video to 2 consultants that are the prestigious government institute. None of them responded. They never said what it is right, wrong, what to do, any action taken or should be taken. No response from the consultant, and in the video showing 92 drops in 1 minute. And they have already lost 1 or 2 patients, maybe because of this. No, I'm not sure. Ensure their observations are taken. Monitor how they feel and report to staff if they think there is a complication. This is what the Council of Europe recommends on empowering and right to participate in policy making. Patients should participate in decisions about their health care and recognize that they should receive adequate and clear information about potential risk and their consequences. The recommendation on patient safety focuses on empowering and informing citizens and patients by involving patient organizations and representatives in developing policies. Patient-centered care can only be achieved if patients' views and experiences influence policy making. That is important. It is not just to listen to them, it should influence the policy making. Disseminate information on patient safety standards and measures to reduce or prevent errors and harms, to facilitate patient choice and decision making, outlining complaints, procedures and available remedies and redressal as applicable. This is again very important. I think that should be looked into. Developing core competencies in patient safety, describing the knowledge, attitude and skills required to achieve safer care for patients. So informed consent is the most crucial individual patient's right. Valid informed consent for a medical procedure can only be given if the patient has received clear information that is adequate. and we have Dr. Sangeeta is when many ethics committees were there, and we have seen the PIS not having adequate information and asking the consent. The information has to focus on nature of the patient's condition, the possible effect and side effects of the proposed treatment, possible alternative and likely implication of no treatment. Patient cannot fully exercise rights on refusing treatment, privacy, access to medical records, exercise self-determination or personal autonomy without providing clear and adequate information. If you don't have any clear adequate information, you can't act on all these things. It strengthens the relationship, this informed consent strengthens the relationship between patient and health professionals and consequently promote patient compliance. See, if you have taken the patient consent, if you have informed everything, taken consent, I think doctor is much more relaxed than the patient. But I feel is my practice, if I have told everything to the patient, then I am more relaxed even than the patient. It also enables the patient to communicate with their family members and plays an important role in managing expectations of possible outcomes and risk of health interventions. A well-informed patient knows what to expect and will be able to deal better with unexpected events, which may prove to be very important from a patient safety perspective. So, patient engagement or empowerment means improving the patient experience, including quality and satisfaction, improving population health, reducing per capita cost of health care. Patients who are more engaged in their own care generally have better outcome. They feel like I have some power in my life. They feel they're more part of the health care. And if patient feels more involved in his health decisions, he will be more proactive and with his health instead of reactive. So if a patient is informed and engaged, he will not react. So there will be less litigation. There is less complication. So it's better you inform the patient, empower the patient and engage the patient. So it is not doctor get to know us, get to know me first for the patient safety. Thank you.
Thank you so much, sir, for sharing your knowledge with the audience. Now for the next session, I would like to invite Dr. D. Sita Ratna Devi, CEO, Dakshama Health. Ma'am is a medical doctor and public health and management professional with more than 30 years of experience. She is also the co-founder of Dakshama Health and Education, an organization which is dedicated to work for access to health, patient education and advocacy. She leads a cross-disease patient alliance in India called Indian Alliance for Patient Groups. Dr. Devi also holds advisory positions at several NGOs and is a strong advocate of patient safety as she focuses on better quality and safety in hospitals and other healthcare delivery institutions. Ma'am, I would like to invite you for your session on patient safety in ambulatory care settings. Thank you.
Dr. Srivastav and dignitaries on the dais, thank you for allowing me to speak on this topic. The good thing about being the last but one speaker is everything that you wanted to speak has already been spoken. So I will not waste your time too much, but I'm going to start with an interactive session. And we heard from Indu saying that there was a Geeta who had no dog. There was no Geeta and no dog, but she was given ARV. So here is a Sita and there was a dog. And in 2021 October, I was bitten by my pet dog when I was trying to feed her medicine. And it was around 8 p.m. in the night. I was alone at home, my husband was not there. And I went to the nearest hospital, which happened to be a kilometer away, which is a multi-speciality, super speciality hospital. And we all know what happens in the evening. There is minimum of staff, your emergency services are there, there's one emergency doctor in your emergency room and one emergency nurse. So when I went and showed up, the usual protocols for admitting or for doing, your registration are not followed. So they sent me straight to the emergency room and they said, go see the doctor. So when I went and saw the doctor, he took out a post-it and on that he scribbled 2 injections. One was antitetanus and another was ARV, and he said, go get this from the pharmacy. So I went to the pharmacy. The pharmacist looked at the post-it and then gave me 2 medicines. He did not give me a receipt because he said, you go get this injections done, by then I will give you the receipt. So I went to the nurse. The nurse, gave me, and I remember telling the nurse that the tetanus injection will be more painful, so give it to me on my left hand and I'll take the ARV on my right. So I took those 2 medicines, forgot to take the receipt from the pharmacy and went home because I was already in pain. The next morning when I got up, my arm was like a balloon. There was erythema all over and it was itching very badly. So as a doctor, I know that there is an adverse reaction that has happened. So I immediately went back to the hospital. Now here is where the problem is. Because I had gone to the emergency, I was not assigned to a consultant. So who is the consultant who is now going to look at this adverse reaction? I went to 3 specialists. All of them said, no, this does not come under me. So then ultimately they sent me back to the emergency room. The emergency doctor looked at me and wrote thrombophobe and said, come back to me after 2 days if this doesn't reduce. So I said, okay, since I'm a doctor and I'm informed, I want to understand how to report this. Who should I report this to? Because at least somebody should take cognizance of the fact that something like this has happened. The hospital did not have a system to record that. So I said, give me the prescription or give me the receipt so that I can report to the manufacturer. Now, when I went back to the pharmacy had not recorded, they had recorded that some medicine has been sold, but they did not record the batch number. And he had 3 batches with him, so he could not give me the batch number. So in such a situation, what do you do? It is not as if I do not know how to communicate. It is not as if I am not informed. It is not as if I did not go to a place that does not have the facility to understand this. Yet an adverse reaction happened. And we do not have the systems to be able to report. If somebody wants to report, what do you do? And if you're not reporting, how on earth are you ever going to capture the information that you require to be able to drive the change that you want to change? So that is the topic that I'm going to start with. And my topic is, let me go to the next slide. So my topic is, how do we ensure patient safety in ambulatory care settings? And we all know what ambulatory care settings is. So most often when patient safety is referred to, it is about hospital settings. And in the hospital settings, it is a captive audience, meaning the patient can't run away. It is, the patient is there for a number of days at least. You have an environment or an ecosystem where there is a nurse, there are other people, there are doctors, there are specialists. So capturing data or capturing information is easy. And when you take the person out of this setting, and we know from the pandemic now that most of the healthcare is not delivered within the four walls of the hospital. Much care is now delivered outside the hospital as well. And if we have to look at patient safety in its totality, then we have to look at the environment outside the hospital, where we have no control. As physicians, if a patient is taking an infusion at home, or is taking insulin at home, we have no control on that. Yet, we have to ensure that there is no adverse reaction or an event that can be prevented. And how do we do that? So what is ambulatory care? Ambulatory care can happen in standalone clinics with people who have their own offices. In ambulatory surgery centers, we know that you have cataract centers and others where you can discharge the patient in a few hours. You have hospital outpatient departments, you have dialysis centers, you have cancer treatment centers these days where you just go and take your chemotherapy and come back home. You have infusions and other daycare centers, and you have also camps. And we know that as government officers, there are many camps that happen. So what are the factors that influence safety in ambulatory care? And this is where the role of the patient becomes extremely important, because here it is the family and the patient who is actually in charge of the care that they have to, take care of themselves. So here it's the role of patient and caregiver behaviors, the role of provider-patient interactions, and the role of community and the health system. And let me touch about another topic which no one has talked about, which has gained a lot of importance because of the pandemic, which is telemedicine and telehealth. So when you are discharging prescriptions or arriving at a diagnosis through telemedicine or telehealth, and the interpretation at the other side is not right, or something happens because the person has not understood right, or the message has not been conveyed right, how do you then manage the situation? How do you ensure that the patient or the family has actually understood the message, or that the information that the physician has to receive to be able to arrive at a correct diagnosis has been actually captured in totality? So with the advent of telemedicine, telehealth, and we all are guilty of WhatsApp, prescriptions over WhatsApps and diagnosis over WhatsApp. I think these are situations which we should be very, very careful about, because there is a lot of information gap and misinformation that can happen even if we have the best intent at heart. And that is where it is important that we ensure that the patient is understanding, that the family is understanding what we are trying to convey to them. And ambulatory care is extremely difficult in terms of management or creating tools or creating metrics to measure safety incidents, because it is very disconnected. So a person, for example, a person might go to a gynecologist, an endocrinologist, and a cardiologist because they have got multiple diseases, but neither the doctors talk to each other because they are all standalone physicians working in maybe separate institutions, nor does the patient share information that they have 3 prescriptions from 3 different specialties. And we still rely on hand-based prescriptions. Even when there is an electronic medical record in place, it does not speak with each other. So there is no interoperability. So if I'm going to one multi-speciality hospital, that prescription will not speak to another multi-speciality hospital. So these are, these are environments in ambulatory care where there is obvious opportunity for something wrong to happen. And when that wrong happens, then you start trying to find out what happened and why it happened. And to plug the gap then is very difficult. So my view to this is that you cannot look at things in small silos. You have to look at it as a totality, as a health systems perspective. And that is what I want to bring you to. The statistics have already been read by a lot of people. So this is the roadmap to advance patient safety in ambulatory care. And there are 4 segments, and this has been taken from a JAMA article from PubMed, from somebody called Dr. Hardeep Singh, who works for AHRQ, and they have beautiful toolkits. I encourage you to go there and see how they measure safety incidents in different settings. So they have divided this into 4 segments, the first one being the science part of it, the second one being the practice, where the doctors are there, the third one being the patients, the recipients of healthcare, and the fourth one being the policy, which is the overarching part of it. So what does the roadmap say? It says multidisciplinary approach to research, whether it is informatics, human factors, system engineering, cognitive and social sciences, all of that has to be integrated, and so that the patient is not seen as a sum total of many diseases, but as one human being in a care continuum pathway. It is very easy to say that, very difficult to implement. Care continuum pathways are very difficult, and we always see patients with multimorbidities. So a cancer patient may also be a diabetic, or a psoriatic patient may have a heart disease, and they may be going to multiple specialties, and it's the patient's choice to choose where they wish to go. You cannot really tell them you have to go into one hospital and you see all the doctors in that hospital. So how do we build the systems that actually talk to each other so that this information is captured in one totality, so that the patient is not actually carrying the information from one doctor to another, but there is a system that is built. And I think the UDID and the Digital Health Mission is in some way trying to address those issues, but we are still at the beginning of the pathway. The second difficult part in ambulatory care is consensus on definitions. And we physicians are very notorious for not agreeing with each other. So how do we have standard definitions on and consensus for measurement methods on safety incidents in ambulatory care? We still have not traversed on that path yet. We are still on quality issues in institutional care. If we want to move beyond that, how do we define the metrics to be able to capture those incidents? And most important is funding. How do we get the funding to have this research? When I did this research to find out whether I had any research articles from India, I found none. Most of it is from the Western world, where they have made an attempt. So some papers from Germany, some papers from Canada, where they have more established systems of healthcare. But because we are so fragmented and we have this huge public and private sector, we do not have any research papers, authentic research papers from India that actually tell us what is the burden of safety incidents in ambulatory care. Coming to the practice part of it, I think Dr. Sangeeta as well as Dr. Arora mentioned this, that there has to be a culture of safety. So safety should not come as a reactive measure, but as a proactive measure. How do we build the leadership to say that we will prevent as many adverse events as possible? And that can only come with investment of time, energy, and resources. And also routine monitoring. So we should have, there are many mechanisms now within the government and public health systems to be able to do that, and we heard about that in the morning as well. But doing that repetitively and learning from that is a very difficult task, and you need resources dedicated for it. So how do we do that? How do you use digital and other technology to make that job easier? How do you use artificial intelligence to pick up where things are being more repetitive than in other areas, so that you learn from those mistakes? And then systemic efforts to promote ambulatory safety culture. And when we are talking of systemic, can we club these standalone clinics to large institutions and share data so that you know where things are not going right? For example, prescription practices. So can standalone clinics share data with large institutions to understand whether prescription practices are right or wrong? I know there is a lot of competition that happens between physicians, and probably this kind of data will never be shared. But can we have some kind of institutional mechanism so that small clinics can be clubbed with larger research institutions or medical institutions to be able to capture this data? Closing of gaps between knowledge and implementation of evidence-based safety practices. And let me tell you, I work with patient groups. I have around 200 patient groups who I work with. There's one patient group on psoriasis in the dermatology section, and we did a survey with the dermatologists to understand whether they are following the ICMR guidelines. So there are standard treatment protocols as described by ICMR, and it tells you exactly what to do when a patient reports to you with, say, a dermatological condition, and there is a screening score in that. 99% of the dermatologists did not use that screening score. Why? Why, as physicians, do we not use standard treatment protocols and screening scores that are there? There is a surgeon who lives next to me. He says he never does a score to see whether the person can bleed to death for surgery. It is a mandatory procedure, but then doctors don't do it, and they say that they don't do it because they are busy. So I think a lot depends on how do we inculcate that culture of safety, how do we not skip steps because we are busy, and how do we make it a habit to do what we are supposed to be doing. And then most importantly, implementation of evidence-based safety practices. So the third is, of course, the patients, and we heard a lot about patient engagement. Can somebody tell me what the tagline is? This year's theme is engaging patients for patient safety, but it also has a tagline. It says, elevate the voice of patients. So how are you going to elevate the voice of patients? We have hundreds of patients coming to our clinic every day. How are we going to elevate the voice of patients? Any ideas? So if you read some of the guidelines and manuals and our national plans as well as our global plans, it has metrics on how do you measure elevating the voice of patients. One is include patients into your advisory boards, technical committees, ethics committees, hospital boards. Get the patient to sit there and listen to what you are discussing so that they can offer solutions. And most people are very defensive when we say that, you know, a patient should sit on your advisory board. But trust me, when you put the patient, and not all patients are at the capacity where they can contribute, and I'll come to that a little later. But if you put the patient there who's actually learned and who has understood what the disease progress is or what the natural history of that disease is, they are able to advise you, you know, this is my life experience, this is not how it progresses. Your textbook says this, but in real life, this is what it is. And that gives immense knowledge. Work with patient groups, as Dr. Arora said. There are many of us as clinicians forget that there are very strong patient groups who are making policy changes at the national level. They work with the Ministry of Health to tell them that these are the drugs we want in the country. These are the diagnostics we want in the country. This is how we want doctors to be trained. This is the kind of advanced treatment protocols that we want in the country. And they learn because they go internationally, they learn from other patient groups, and they interact with several people. And then they bring that knowledge back into the country and they say, this is the process by which we can do. I remember I worked with one patient group where we had a phase 2 drug. So phase 2 clinical trial drug in no condition can be brought into the country. The Drug Controller General will never give us approval. But that drug was life-saving for a disease which had no treatment. And when it had no FDA approval. But when this patient group and all the patient groups that were working in that particular therapy area went to the Ministry of Health and said, listen, this is something that could save the lives of a few children. Can we bring this drug to the country? There were deliberations. At the end of around 6 to 8 months, we actually got the drug, and it went to 40 children. So it's not as if patient groups can't do much. That's a misnomer. There are many patient groups who actually are advocates. The patients themselves are advocates. They are doctors. They are learned professors in universities. And they bring a lot of knowledge from the academic world along with their own lived experience. So I encourage that you reach out to patient groups and learn from them. Try to bring them into your advisory boards and into your technical advisory groups, and they will add a lot of value. Then patient engagement informs redesign of processes along the entire care continuum pathways. And as I said, a patient is not a sum total of their diseases. They are human beings. And if you listen to them, then they will give you a lot of insights on what is happening to them and why something is not working right or why something is working right. Then look for new strategies and tools to promote partnerships with patients and caregivers, and use of health IT, as I already said. At the policy level, we already are doing a lot, and I'm very proud to say that I just returned from Geneva. As a country, we are one of those that are very forward in our entire program and design for patient safety. So, and 2 of us, in fact 4 of us were there from India. From the 50 or 60 odd delegates, there were 4 of us. That's a very strong representation from India. And but we are a very large country. So while we are doing a lot of good things at the top level, is it percolating down to the last village or last mile? I think that is where, as people and representatives from the state, you can do a lot. There is a lot happening at the national level. There are a lot of guidelines coming up. There's a lot of discussions like this, but can we have similar discussions at the state level with patient groups in your state, or at a district level with patient groups in your district? Maybe that would add a lot of value. And then design new frameworks for governance, oversight, and accountability to support ambulatory safety, and a National Patient Safety Center to coordinate and lead the efforts at the national level. We already have an HSRC doing that. I already spoke a lot about why patient safety is important in ambulatory care. And one of the reasons is face-to-face interactions in OPD is very limited. So messaging, even though we talk a lot of communication, the opportunity for communication becomes very small. There's another thing that I would like to highlight. In Geneva, we talked about a patient rights chapter. So what are the rights for patient safety that we should enforce? And one of the discussions that came up was that there can be no right without responsibilities. So how do we ensure that patients understand what their responsibilities are? Our communication usually is one way. We tell them, you do this, you do this, you do this. But then if they do not do it, what are the consequences? Do they understand that? And who is responsible for those consequences? Do they understand that? I think that communication needs to happen. So I will not go through all of this because we are already running late on time. So one more thing that patients should understand is if something happens, where should they go? As I said, we do not have any mechanism to capture patient-reported harm. Right now, our system is go to your physician, and the physician then records what harm has happened, and you hope and believe that this physician has then reported to the national reporting system. Trust me, it doesn't happen 90% of the time. I work, and as a physician, I know that because my classmates and my juniors, my batchmates, everybody is there in the system. Usually, harm is not reported due to various reasons, but it is not reported, which means we do not even have authentic data on what is the burden of harm. So if institutions are not reporting, is there a mechanism where the patients can report? And they may not report to the same portal, but is there a mechanism? Because there are other countries like, say, Malaysia or Thailand, where the patients can actually report directly to a government portal and say, this is what happened to me, this is the facility I went to. They don't name any doctors or any individuals, only the facility. And they say, this is a facility, this is what I was prescribed, and this is what has happened. Can we capture that data so that we have more broader data to work on? Then the nature of interactions between patients and providers and between different providers may also be a source of adverse events. Patients consistently voice concern about coordination of care, particularly when one patient sees multiple physicians. And we all know that physicians are very poor communicators amongst their own fraternity. We also talked about poorly handled care transitions. So usually when a discharge is given, is the discharge explained? Is the patient told what to do if something is not working right? And again, another real life example. We work with stroke patients. So when stroke patients are discharged, they either have aphasia, they are not able to speak, or they are not able to eat because their throat is affected, or they are not able to walk, or a combination of all these three. So when they are discharged after 10 to 15 days, they are usually told to do physiotherapy. Nobody teaches the family how to feed the patient. And they really struggle because they don't know, and the person is not eating. They don't know what to give to the patient. The patient completely refuses after a point of time. And because they are refusing, they develop weakness and they do not do their physiotherapy, and that has a detrimental effect on the long-term outcomes of recovery. And time and again, the family says, my patient is not eating, but nobody listens. Nobody listens. What is the reason why that patient is not eating? Their patient is not eating not because they are not hungry, because they are not able to swallow. And nobody tells the family that if the person is not able to swallow, what do you do? What do you give as a feed? That kind of discharge advice needs to be given better. And it is universal. It happens in all hospitals. Nobody spends time to explain the discharge summary to the patient. Now, when a clinician is not immediately available, and we have all faced this. So my treating physician disappeared because they were busy in something else. Another physician came who has no clue about what happened to me. And the poor person has to now manage the situation and therefore does it to the best of his or her ability. But what happens to me is I have not understood what has happened, and therefore I go back even more confused than when I came to the hospital. And either I go to another hospital or a doctor because I've lost faith in this system, or I stop the medicines, and neither of which is a good outcome of a physician not being available. So if I'm not available and I'm a treating doctor for my patients, how do I give instructions to my team that, if I'm not available and somebody else is going to stand by in my place, what is that person supposed to do? That communication also needs to happen. I'll briefly touch upon the methods to study ambulatory safety, and we do not have data in our country, but I did want to touch on this. The usual ways is chart reviews, administrative data, reports from clinicians and patients, observations, and survey. And these tools are very, very inadequate because they give a very limited view of what is happening in ambulatory settings. So as a global community, I'm not talking just of India, but as a global community, we need to look at what kind of methods and research methodology needs to be developed to be able to capture incident or patient safety incidents from ambulatory care. Some of the challenges: research funding for studying outpatient safety is very limited. There is inconsistent definitions of safety events, as I had referred to earlier. Achieving consensus around definitions and measurement methods will enable larger epidemiological studies, which currently are not there. And we need to look at mixed methods to help develop and assess safety interventions in disease ambulatory settings. All these has already been touched on, so I'm going to skip this part of my presentation and go straight to patient engagement, which Dr. Arora has already referred to. And again, in this, there are 3 or 4 things that are very challenging. One is language, and digital could be an enabler, but could be a disabler as well. So many people think that with Zoom, you are able to communicate to a larger audience, and that the message is going clear, but that is not true. With the advent of technology, there are a lot of people who are actually marginalized, either because they do not have access to technology or because the language in technology is predominantly English, and therefore they are not able to understand. So if you have a telehealth or telemedicine program, you have to make sure that the consultation is happening in the language that the person understands. English cannot be the medium. I will not go to all the medication part of it because Dr. Sangeeta Sharma already covered all of these. There was just one thing that I wanted to touch upon, which is self-care. And self-care is getting a lot of momentum the world over, and this is happening more in the SRH world, the sexual and reproductive health world, where they're talking about taking abortion pills and managing post-delivery on their own in their home settings, etc. But it is also catching up now with cancer care, with palliative care, with infusions for, say, hemophilia and other diseases, and insulin. Patients with type 1 diabetes or type 2 insulin-dependent diabetes, all these are talking about self-care. And we still don't know how to measure any incidents in self-care settings. How? There is no metrics there right now to do that. And in these settings, I think it's very important that people spend time to teach patients what to observe, what to understand, and what are the red flags. Are there any red flags that they should be alerted to? And if those red flags are there, who should they be reporting to? Is it the nearest primary healthcare center? Should they go to a district hospital because it's an emergency? So how do we communicate that is very, very important. In conclusion, to address complexities of ambulatory care, future workforce competencies could emphasize system thinking while incorporating interprofessionalism and team-based care. And I think this is a missing concept. We do not work in teams. In our own little silos, we work in teams, but across specialties, we do not work in teams. Again, another important thing, payment policies currently focused on patient volumes, and this applies to private sector, should place greater emphasis on safety to overcome common barriers such as inertia, lack of leadership support, resources, and dedicated teams to identify and mitigate risks. Policy initiatives should build robust frameworks for governance, oversight, and accountability. And accreditation bodies and payers should adopt more effective models to promote routine safety measurement. Meaningful engagement, etc., has already been referred to. I think one strategy for gathering patient safety data from patients is to modify existing patient experience surveys So we look at how happy or sad the patient is. We don't consider collecting any safety incident data. Maybe we could modify our experience surveys to include that data. And Health IT has opened up new channels for patients to generate and use data. So when you have consumer goods and you can actually rate them and say, whether the product has worked to your expectation or not, I think we can do that for health as well, and be able to collect data. So all this is something that I will leave the presentation with you so that you can have a look at it. To enable change, large integrated delivery systems should leverage their infrastructure to create ambulatory safety programs. So again, another experience that we had, I was working in an HIV clinic, and a person on ART reported to our clinic. This was in the private sector, and collapsed. Now, we had not built a system for referral. In the sense, we knew how to refer, but then we did not know somebody would actually collapse on our table, and then we had to arrange for an ambulance and see which hospital to refer to. So those kind of referral mechanisms need to be built so that people know exactly where to refer. And last but not the least, a national knowledge platform could serve as a repository for both existing and emerging evidence-based strategies to facilitate implementation. I think Dr. Srivastava referred to this, that it is work in progress. Thank you so much.
Thank you so much, ma'am, for your valuable thoughts. Now I invite Dr. Deepika Sharma, Lead Consultant, Quality and Patient Safety, NHSRC. Dr. Deepika is a health system professional with over 14 years of experience in public health systems. Ma'am being a core member for developing technical guidelines, including patient safety framework, she is also a part-time faculty for quality and hospital administration courses run by Eminent Educational Institute. Now I invite you, ma'am, for your session on promoting patient engagement under NQAS. Over to you, ma'am.
Thank you, Deepika, and a very good afternoon. So, being a last speaker of this panel discussion, so a lot of stress on me to wind off as soon as possible. But before I start, we have invited this time the state consultants as well as the district consultants over here, and you might be wondering that why NHRC has called us and bombarding us with so much of the knowledge, right? So just to bring the more clarity, my presentation is going, in my presentation I am going to take you through certain basic concepts of the patient engagement, and then how and at what level we are in the country in this particular scenario, we are going to discuss about that. If I'll talk about like my previous speakers has already talked about the burden of the patient safety, and we all know that the patient safety is the fundamental element of the healthcare. And there are evidences which shows that there is a kind of harm done to the patient specifically during hospitalization, as well as during ambulatory care, as well as during primary care. And there are evidences which shows that these type of harm can be reduced up to the 50% and more if patients are engaged. And I hope my previous speakers has also talked that taking all these things into the consideration, that this theme has been taken by WHO this year for the patient safety. So there are many definitions of patient engagement, and most of definition my previous speakers has already talked about, and J.S. Arora sir has beautifully explained about patient empowerment, involvement, as well as the engagement. Now if I'll talk about patient engagement, in net it means strengthening the people who are basically user of the services, not as a patient, but also as a kind of partner, specifically in terms of the healthcare policies, as well as the practices. And we totally understand that patient engagement not only improve the health outcome, reduce the cost, but also improve the efficiency and provide the high quality services. If I'll talk about patient engagement, then there are three major levels where we have a kind of barriers in terms of patient engagement, and these may be at the patient level, it may be at your service provider level, or it may be about the community. If I'll talk about patient side, then in a country like India, already we have less literacy rate, but apart from that, when we talk about the health literacy, that is much less. And there is unwillingness also. Like, for example, you have a headache for 1 day or 2 days. We don't like to visit to doctor. We keep lingering. Sometimes we'll take the Disprin, sometimes we take the Combiflame or something like that. So there is unwillingness, as well as there is some kind of barrier in terms of culture. It may be barrier in terms of genders and other many things. If I'll talk about the service provider or healthcare professional, these are kind of knowledge, attitude, and practice related gaps are there. And when we talk about community, a lot of awareness specifically in terms of the patient safety is very much required. But before that, like awareness about the health is also very much important. So we usually all go to watch movies, and in the beginning of movie, we usually get an ad from the tobacco department, right? Somebody का वो गंदा चेहरा वो दिखाते हैं, दिखाने के बाद, and most of us don't like to see that particular advertisement. But at same time, we have from Government of India for the NCD program, there is Rajkumar, which says today we will take less sugar, today we will take less namak, etc. All these type of awareness generation is available. But even after looking into that particular awareness generation, there is a kind of unwillingness on a patient side, on many sides, specifically in terms of talking about it, or interacting with our physician, or asking the question about all these things. Now, this is the model already Arora sir has discussed, but this is the model for the patient and family engagement, which was given by American Institution of Research. If you look into this particular model, it has basically two things. One is your level and continuum of patient engagement. In level, if I'll talk about, it is basically service provider level, organization or hospital level, and policymaker level. And other side, it is consultation, involvement, and partnership. So if I'll take example of service provider, so in consultation, it is expected in the patient engagement that whatever disease condition you are suffering from, your doctor is supposed to give you the full information about it. And most of time, this component is missing. Apart from that, for giving you the treatment, he has to give you the choices, and the preference is taken from the patient. And last, whatever the preference patient is supposed to choose, he or she is this may be based on certain scientific or evidence basis. Similarly, if I talk about the organization, then whatever care you have provided, its feedback is supposed to be taken, and after taking these feedback at involvement level, we need a kind of patient advisors at the healthcare level, and also we need to include patient in our quality and safety improvement committees. If I'll talk about policymaker level, we conduct a lot of survey in country like NSSO, etc. So a kind of focus group discussion is required specifically for the patient opinion about the patient issues. And these issues are further supposed to be taken into consideration for the research topics, etc. Now, if you look into this particular model and self-analyze, because we have state and district people who are sitting over here, you will find it out we are not doing even 1% of it, right? Now, if I go further, Government of India and WHO has come up with patient safety framework way back in 2018. And as Srivastav sir has discussed, that this framework has given us certain objectives. These objectives have certain priorities. If you look into its first objective and priority number 1.3 and 1.4, this is basically talking about communication of the patient with the doctor, And priority 1.4 is talking about not only the communication engagement, but apart from that, there is a kind of system at place, like to report the grievances of the patients, having a system to monitor the patient safety indicators, as well as certain kind of standardized material for the patient awareness. We have lot of awareness material available, but there is no standardization. Material available in private sector, in tertiary care institution, in primary sector, but there is no standardization. Even state-specific materials are available. If we talk about the journey of the patient safety in India, we have started way back in 2018, and follow to that, every year we are conducting webinar, we are doing the pledge, etc. And in 2022, Government of India has developed the Sakushal tool, and this year we have even recognized the champion who has at least started the assessment in using the Sakushal tool. If I talk further about the journey of the quality in the country, we started in 2013, and that time INQUAS came into existence, and further to strengthen the many of the safety concepts like infection control, we came up with the Kayakalp. To strengthen the components specifically in terms of the mother and newborn, Lakshya came into existence, and further to the child up to 12 years, Muskan came into existence. In all these sections, somewhere we are covering the basics of, patient safety, right from medication safety, surgical safety, and many other things. But they all were not integrated, and for integration we brought Sakushal at place. So Sakushal helped us to bring an integrated score of all these particular components, and I just want to show the reflection that where we are standing, because NHRC do the external assessment of all the hospitals who basically undergo the INQUAS assessment, and this is the result of 398 healthcare facilities. So you can see that our average score specifically in terms of the patient safety in the district hospital is coming somewhere around 87%. Now you might be thinking that we seems to be very negative, that we are not doing anything, but the scores are saying something else, right? If you look little more critically, this is not a pie chart, this is just a kind of reflection, and this particular thing is telling me that although we are doing better in many of the area of concerns like patient right, infection control, your clinical services, but we are still lagging behind in terms of your infrastructure safety, your fire safety, your community engagement, as well as risk management in the quality management system. So this analysis is based on INQUAS tool 2018. Many time people come to us and they said कि मैम आप हर 3 साल में guideline बदल देते हो. Now why we changed the guideline? The reason is that the basic level you have already covered. So if I'll talk about the medication safety basics, so you can find it out that in clinical section we are getting 94% of the score. So we need to now push ourselves, pull our sleeves specifically to move up to the intermediate level and then further to the advanced level. If I talk about the Sakushal, you know that there are 4 areas of concern under Sakushal, and if I talk about the systems of the patient safety, under that one section is about the patient engagement. So I requested my team last night to just quickly do an analysis of all the data that has been shared by the state specifically in terms of the Sakushal. So in patient engagement, we have approx 20 elements, and out of that 20 elements, there are 10 or 12 elements I have jotted down in this particular slide, and you can find it out that here we are talking about measurement of the patient experience, having patient safety champion, having simple patient right charter, having some type of the poster or pamphlets for it, and medical accessibility of the health records, etc. Now, under Sakushal, we do the internal assessment once in a 6 months. So twice in a year, we do the safety assessment of at least for the district hospital, and you will be surprised to see the result. So this is the self reported data. This is the self-assessment score of overall country, where 258 healthcare facility has reported, and Sakushal data is 68%, while in patient engagement, we are 51%. If I will drill down this particular 51%, we will find out that there is a lot of knowledge gap specifically in the people who are assessing, as well as the people who are implementing these concepts in the healthcare facilities. Just to conclude, that what we have learned out of both, in KWAS and Sakushal, the 2-3 major things. One thing that specifically in terms of patient safety, we need to upgrade now to the further standards. We have already achieved certain basic standard. Now it is time to move to the intermittent level of the standards. And we are going to introduce, or we have already introduced many of the new concepts in the system, like clinical governance and leadership. We have recently added in District Hospital 2023 version, and people are not very comfortable about this clinical governance mechanism. Risk management, we are becoming more and more stringent over a period of time. Even in the clinical side, we are now looking into the drug reconciliations, all the concepts that Dr. Sangeeta has discussed. We are looking into these concepts. Again, I just want to say that as an assessor, as the implementer, we have to look for further, and we are supposed to look into that, like what we are assessing, whether the intents are fulfilled or not, or it's not just mere that we are give the 2 marks and our responsibility is over. No, we are contributing in the whole system when we are assessing them, when we are implementing the systems. Apart from that, of course, lot of awareness generation is required, both at the patient as well as your service provider level. And when we talk about service provider, of course, a kind of, maybe certain soft skill training, maybe certain, change management trainings are required, so that their, specific or particular mindset changed over a period of time. Apart from that, these all concepts need to be introduced under the in the undergraduate and postgraduate courses, etc., so that the fresh students don't feel like what now doctors are talking when they reach to the healthcare facilities, etc. Explore the alternative way of the communication. Of course, as we have talked or stressed upon, Ratna ma'am also has talked and stressed upon IT system. We have already at place Abha IDs, as well as we have Ayushman digital health missions, etc. So we have to leverage all these particular platform for further improving our healthcare records and their accessibility, etc. Organize the camp to raise the awareness. So this year we are celebrating the Patient Safety Week, and during this week we have made patient safety as a one-off agenda in the health melas. So in the health melas or during palliative care visits in the home, we are basically raising the awareness of the general public on, asking for their needs, about asking the question or encouraging the patient to ask about the questions on their specific requirements, etc. Of course, we need to recruit or train the patient volunteers, and when we talk about recruit and train in our system, particularly in a scenario like India, we have patient support groups, etc., but most of time they come, they attend the meeting and they go. So how they are supposed to be engaged, again, Arora sir has given that emphasis further also, that we need to explore not only in the tertiary care level, but also in my secondary care as well as in my primary care levels. And standardization, of course, very much is required. We have n number of material right from international level to the state level, facility level, district level. They are roaming around, but these all material need to be standardized, and maybe some national repository can be constituted for all these policies or all these material or the videos that we are using in the healthcare system. So thank you so much, and I just end my presentation as ma'am said in the beginning that without communication there is no engagement, and without engagement there is no safety, and without safety there is no quality. Thank you so much.
Thank you so much, ma'am. With this, I would like to take this opportunity to thank all the speakers for sharing their valuable and knowledgeable insights with us today. Now I invite my team members to please give a small token of appreciation to Dr. Jayant Srivastava, sir.
Now I request my team members to please present a small token of appreciation to Dr. Indu Arneja.
I request my team members to please present a small token of appreciation to Dr. Sangeeta Sharma.
I request my team members to please present a small token of appreciation to Dr. J.S. Arora.
I request my team members to please present a token of appreciation to Dr. Ratna Devi.
I request my team to please present a small token of appreciation to Dr. Deepika Sharma. Moving ahead, I would like to invite the team of Assam State on stage to share their experience on patient safety with all of us. I request all the team members to please conclude your presentation within a time frame of 4 to 5 minutes so that we can timely wind up the event.
Team Assam, please.
So very good afternoon to all of you, respected Jayant Srivastava sir, and all the panel experts and dignitaries coming from different states of India. So we are just sharing some of our experience regarding the patient safety module implemented in our state of Assam. After getting the instruction from the country, we have estimated around 21 number of district hospital and 16 number of SGCH and CHC, where the scores in the internal assessment score was for the district hospital it is around 65%, and for the sub-district hospitals we have around 60%. And the major findings of the common gap identified during the assessment in the area of concern A, patient care process, we have a standard treatment guideline during the presentation in terms of antibiotics need major attention. Already most of the panel experts also accepted this thing, which is common for the entire country. In our state also the same thing. Second, time-bound action plan for is to be prepared for improving the low-performing attributes and prescriptions practices, which are also described. And in all health facilities, the maintenance of storing of high alert medicine in a secure and safe and demarcated places, we are not yet to achieve this thing for all our hospitals. Though we are trying at our best level, and the counseling of the patients and prescriptions and the related behavior always an unmet need for the patient safety in most of the hospital settings. It may not be for for the entire patient, but most of the cases it is missing. And the second concern is the clinical risk management, the periodic validation of reagents, strains, media kits, etc., and then cross validation of laboratory tests. Already discussed all the points. And geriatric patient care assessment tool is not being implemented in our district hospital and below. Only certain activities has been started in the state in the medical colleges only. The non-availability of the demarcated triage area is also one of the concern for the clinical risk management in our hospitals. Again, the safe care environment, the fire safety certificates are not achieved for all our hospitals because there are some issues with this fire safety, this certification procedure. Actually, we are trying to get the certification for all the hospitals, tying up with the fire safety department of Assam, and things are in progress. And then authorization certificate from the pollution control for biomedical waste management is also one of the concern. Though we are doing the practice in our hospitals, but sometimes certification is also issue with the pollution control because there are a lot of they have in different time they are updating their process of biomedical waste management. Now they are talking about the common biomedical facilities, etc. So in some places we could not get the certification. And regarding comprehensive disaster response plan for all hospital, we need to review the updating as per the recent development in this sector because disaster may be due to the climate change and other thing. The extreme weather event and other thing disasters are coming in a big way. And as per the suppose if we talk about earlier 25 years back, now the situation is different and now technology is also coming and the standards are now upgraded as per the IPHS and even international standards. So we have to upgrade the health facility as per the disaster response, this new settings and new standard. And regarding electrical safety measures, we are doing regular monitoring and this thing, but still this is a concern because there are installation of safety equipments, there are new standard of safety equipments, and in our all settings, we have to replace those retrofittings for safety equipments. This is one of the need for different health facilities of our state. Then again, the patient safety system, we have a we have to comprehensive patient safety policy plan need to be reviewed, and assessment tool for patient safety measures to be implemented periodically. This is not much done for our health system. And also regarding risk evaluation and assessment tools is to be used regular basis, and gap is to be identified and proper action plan to be prepared for different hospitals. These are the key learnings from the state after implementation of this patient safety module. Circle of continuous learning for patient safety, 5 moments for medication safety app, then comprehensive geriatric assessment tool, and then as low as reasonably achievable principle to ensure the radiation, and thermostatic control system, grievance redressal system, leadership and governance, and patient empowerment system. And regarding the key improvement under facilities, we have air quality index in patient care area, then structural safety for all the hospital infrastructures, then ensure safety in dialysis services, ensure patient safety in all the national health programs, because all the national health programs have different patient safety standard for different attributes, and it is to be ensured because only then all the programs ensure the safety, then only we will have a consolidated decision safety measures for the patient. Then hospital alert code is also very important. Thank you.
Thank you so much, Team Assam. I would request Dr. Shikha Sharma to please present a small token of appreciation to Team Assam. I request Team Chhattisgarh to be ready for their presentation. Team Chhattisgarh, please come for your presentation.
Good afternoon to all. We are representing Chhattisgarh. So our gap assessment and other things are there. Backgrounds of detail of Shakushal tool, implementation in public healthcare facilities, type of facility DH, 18, number of 18, average score obtained 78%, common gaps identified in assessment, area of concern, aseptic patient care processes, lack of standard prescription format, prescription audit analysis is not being done on regular basis. Need to update STG and antibiotic policy, define and display of high alert drug doses and drug formulary, lack of proper reporting of ADR, poor patients identification system, lack of training on hospital disaster management and emergency response. Area of concern B, clinical risk management, incomplete documentation, incomplete safety checklist, lack of awareness on radiation safety, lack of proper signages in and around radiation department. The staff is not skilled enough to ensure safety in emergency care. Common gaps identified in assessment, area of concern C, safe care environment. The facility has no established mechanism of periodic inspection, structural safety, electrical safety and fire safety. Lack of workstation management, lack of training on safe usages of hazardous sustenance during induction or whenever a new hazard is introduced into the work area. Lack of disaster plan, lack of implementation of infection control program. Area of concern D, patient safety system, policy on hospital risk assessment and management is not prepared by the hospitals. Committee team in this regards has not been formed. Inadequate support of staff. Key learnings, importance of patient safety policy, awareness about LASA drug management, how to prevent the medical errors, benefit to use of safety audit checklist. Key improvements, increases awareness about the patient safety and quality among the staff. Department checklist for assessing safety and risk is being filled by the hospitals. Infection control monitoring through audit. Physical audit, power audit and fire audit are being done on interval basis. Identifying the trying to fill the gaps. Thank you.
Thank you so much, Team Chhattisgarh. Now I request Ms. Nasreen Nikat Khan to please present a small token of appreciation to Team Chhattisgarh. I also request Team Dadar Nagar Haveli and Daman and Diu to please be ready with their presentation. Team Dadar and Nagar Haveli and Daman and Diu, over to you.
Good afternoon, everyone. I'm Dr. Richa Jog. I'm the State Program Manager for the UT of DNH and DD. And this is an overview just for information. Like the UT of DNH and DD is very small. We just have 105 facilities, 3 district hospitals and 1 sub-district hospital. These are some glimpses of the hospitals. Circuitial assessment was implemented in all the district and sub-district hospitals in the UT. District hospitals, 3 facilities were assessed. We had a score of 83, and SDH was assessed, wherein we received 73%. The common gaps that were identified were the safe patient care processes. Area of concern was identification and assessment of patients prone to old age and instability, urinary incontinence. Key improvement under the facilities that we devised upon were that patient identification unique system could be devised for high-risk cases, especially like tagging of OPD cards, like color coding. We could also dedicate queues for high-risk patients like ANCs, geriatric care, provision of ramp, wheelchairs and walking aids. And volunteer groups can, like in COVID times, we had these NGOs and self-help groups who were volunteering to, assist all these high-risk patients. So we could actually consider doing that again. Area of concern B was clinical risk management, wherein safety in palliative care and safety in specialty clinical services and high-risk clinical processes was an issue. The key improvements that we discussed upon was early identification of conditions and pain management could have been done. Treatment plan can be immediately told to the family members, and a bi-directional follow-up can be done with the medical officers, the staff nurses, as well as publicly. We can also ask the health and wellness centers to create awareness sessions even in public facilities and their houses, house-to-house contacts. The area of concern C was safe care environment, which was preventive measures for safe care patient handling and safety gear at workplace for staff. The key improvements were obviously the ergonomics for the facility staff has to be taken into consideration, and we have planned to rectify the same. And area of concern D was patient safety system, wherein identification and investigating adverse events, errors and near-miss incidents. So the main key improvements that we could devise upon was root cause analysis can be performed, and corrective and preventive measures and action plans can be devised. The key learnings that we have is proper counseling and engaging patients and their family members. More digitized technology can be used to reduce human errors. Training and feedback mechanisms should be devised, especially training of our health staff. And quality tools such as RCA, CPA should be used in all departments to enhance patient safety. That's it. Thank you.
Thank you so much, Team Dadar Nagar Haveli. I would request Ms. Rachna to please hand over a small token of appreciation to Team Dadar Nagar Haveli and Daman and Diu. Also, I would like to invite Team Kerala for the next presentation. Team Kerala.
Good afternoon, everyone. I'll wrap up my presentation soon. Okay. So actually we did our patient safety assessment checklist, ran in all of our DH. We did in 100% of our DH, and we got an average score of around 68%. What we could notice is that the scores were lowest in the patient safety system. Area of concern D, the patient safety system, which was around 55, and all other area of concerns, we got the patient in safe patient care process around 78%, clinical risk management around 72%, and safe care environment around 75%. But in patient safety systems, we were lacking behind. And in the case of Taluk hospitals, SDH, we have completed in about 18 Taluk hospitals. The process is ongoing, and the rest of the 70, the process is ongoing. We'll be completing it within 2 days. And the common gaps identified in assessment was The major gap identified in the safe patient care process was in the safe patient handling, that is prevention of accidents and falls, and there was lacking of established procedures for identification and assessment of the patients prone to fall, especially those with epilepsy, eclampsia. So we identified that gap, and we are planning to give the trainings to identify those patients who are prone to fall. And instructions to prevent falls are now documented in the care plan. And coming to the area of concern B in the clinical risk management, in the specialty clinical services, especially in this intensive cares, the safety, there was no established parameters for safety of electrical establishment. That has to be looked into. And the ICU has a dedicated earthing pit system available, but the other parameters for safety needs to be looked into. And there was no adapters for ensuring the provision of electrical outlet and inlets in some of the facilities. And common gaps that could be identified in assessment in the area of concern C or the safe care environment was like mostly related to the human factors or ergonomics, that is the man and material machine handling. The facility uses safe hospital beds and furniture, and in that case, the furnitures in most of our district hospitals, like many in your states, must be like the old type of furnitures, that is heavy beds and coats, and we have to replace or find alternative solutions with those with wheels or lightweight casters which could roll easily and are noiseless and have good brakes. That has to be looked into. And we have found a gap that there is no training for hazardous material handling, especially among the healthcare workers. So that will also be looked into. And the major gap was in the patient safety assessment system that I have already discussed. So we need to look into the areas to develop process for the patient safety assessment, especially in clinical risk, identify or engaging the patient into that process. That will be looked upon. And the key learnings from our side is that we can improve on our medication safety and also the general safety in clinical care. That will be our top priorities this time, and also engaging the patient as per the theme in this year's patient safety day celebrations. So that is what we did in Kerala. Thank you all.
Thank you, Team Kerala. Now I request Dr. Vinita Dhankar to please present a small token of appreciation to Team Kerala. I also request Team Odisha to please be ready with your presentation.
Good afternoon. Enhancing patient safety in healthcare facility. In Odisha, we have 32 DHS, out of which we have conducted assessment for 21 DHS, and the average score is 65.4. Major gaps. In case of safe precision practice, most of the handwriting need to be written in capital letter, but the patient load is very high. Minimum, a doctor have to see 150 patients per day. So it's not possible in their case to write all the precision in capital letter. Second one is rapid response team for all kind of adverse events. There is one dedicated team, but for all the adverse event, there is no dedicated team in most of the hospitals. And infection prevention and control, bed with adjustable height and side rails. It's not available. For pediatric wards, bed with side rail is available, but for other cases like for vulnerable patients, in ICU and pediatric ward it's available, but for other wards it's not available. So we have to change that. And communication and transition of care, it's a major concept, major problem, because during shift change, as the load is very high, during shift change, in some of the hospitals they are providing sufficient time for bedside handover of the patients, but in some of the case, as per the score, it's not available. So we have to change that. Then hospital emergency response code, the staffs need to be trained on that. Risk and hazard identification and communication, it's a gap, and the score is low in our state, as per the assessment hospitals. Operation site marking. As per the checklist or as per the requirement, operation site need to be marked, but in every case, it's not done. So area of concern, site safe care environment. For fire and old buildings are not seismic safety. So as per IPHS norm, wherever the new buildings are coming up, they are as per the requirement. But in the old building, it need to be changed. Area of concern D, patient safety system. The facility has valid NOC for fire safety. Wherever the new buildings are coming up, it's as per the requirement, and fire safety is, we are getting fire safety NOC. But for the old building, as per the requirement, though the fire extinguishers are available and staffs are trained and fire extinguishers are available, NOC is not getting. The hospital are not getting NOC because the buildings are old and there is no 20 feet road all around the building. So, and the valid certificate for electrical inspection, lift license, in most of the hospital it's available. Key learnings. Regular training of staff of the hospital, both for soft skill and technical improvement need to be done. Safe audit to be conducted. Safety audit need to be conducted for all the hospital. Though we have 32 DHs, out of which only 21 have conducted using Shakusal. Side rail to be provided for all pediatric beds and as well as the vulnerable patient beds. Also in medicine ward it need to be provided. Communication during transition of care need to be strengthened. Key improvement under the facility. Till date, all the staff of the major hospitals are trained, all the staffs of the healthcare facilities are trained on infection control, IPC, infection prevention and control program. Key staffs of DHS are trained on patient safety. IAPH was conducted 6 batches of training in our state and most of the hospital staffs are trained. Surgical safety checklist, safe anesthesia checklist and safe bar checklist are used in almost all the hospitals. Then all facilities have adequate firefighting equipments, but due to space constraint or due to old building, some of the hospitals are not getting fire NOC. Robust biomedical waste management system is there. Thank you.
Thank you so much, Team Odisha. I would request Ms. Nasreen Nikhat Khan to please present a small token of appreciation to Team Odisha. With this, I would also request Team Uttarakhand to please be ready for their presentation. Team Uttarakhand, please.
Good afternoon, everyone. Myself, Dr. Priyanshi Srivastav, State Consultant Quality, Uttarakhand. First of all, I would like to thank NHSRC for inviting us and appreciating our efforts. Thank you so much, Jain Srivastav, sir. Quickly, we'll finish. We have assessed total number of district hospitals are 13 in our state. So we have assessed 13 district hospital, SDH 4, and overall score was around 65 and 60. Now, the common gaps in each area of concern, first, safe patient care processes were regular prescription audits, hand hygiene audits, and action plan. They have to be maintained regularly at all level of facilities, and of course, training under hand hygiene and medication safety. Area of concern B in clinical risk management, basically clinicians and facility in charges need to more have induction trainings of medical safety and surgical safety. And area of concern C, safe care environment. Due to hilly region, we have a lot of space constraint also, like the open space at the entrance level for free movement of ambulance, parking space, adequate spacious room for patients, etc. And of course, zoning of the departments. Area of concern D, patient safety system. Of course, due to space constraints, we are having less availability of ramps with the lifts and all, especially in the UPSCs and HWCs, and of course in SDH level also. Patient awareness campaigns through patient engagement tools such as 5 moments of medication safety and self-care after discharge, etc. They should also be organized at facility level. Key learnings are basically, as we all know, that patient safety is the utmost priority. We should be taken care at all the levels. Now the Shakusal tool checklist is a self-assessment tool which have given us so much help and support to implement the patient safety practices in all the levels of the facility. Now the periodic trainings on patient safety and regular monitoring also at the facility levels, we have to take care of that also. Key improvements which have to be undertaken are basically the facility staff needs more induction and mock drills in order to implement better patient safety practices. Facility level analysis should also be done in order to better maintenance of report. Incidences has to be properly maintained, and of course the patient safety activities which has to be performed at all the level of the facility in order to maintain the quality care. Thank you so much.
Thank you, Team Uttarakhand. Now I request Ms. Rachna to please present a small token of appreciation to Team Uttarakhand. I also request the team from State of West Bengal to be ready with your presentation.
Good afternoon, all the dignitaries present in this hall. In West Bengal, we have implemented a Sakushal checklist in all of our DHS, that is the 14 number of DHS, and our average score was 64.6% only. And one SDH took part in the Sakushal internal assessment, and they scored 81%. And the common gaps observed during our assessment, we found that under safe patient care processes, rail cot and Fowler's bed with adjustable heights were not available in inpatient area. That is increasing the risk of patient fall. Venous thromboembolism risk were not being assessed in IPD. In first half, Indu Arneja ma'am pointed out the importance of patient communication during their inpatient care. So we observed that SBAR and IPAS communication tool are not implemented during intramural transfer. Identification and monitoring of potential risk and hazards exposure was also lacking, that is HIRA, hazard identification and risk assessment. Under clinical risk management, we observed that multi-morbidity cases, vulnerable patient, high-risk patients were not being identified in actual. And most importantly, the roles and responsibility of the caregivers are not being defined. So that compromising the patient safety. Under safe care environment, we have observed that call for help, safe lateral transfer practices are not followed in inpatient area. And the caregivers have to sit on a wooden stool for long hours, like 8 to 10 hours. There is no provision of ergonomically designed furniture or fixtures to the healthcare providers. So we are lacking behind. In area of concern D, patient safety system, the reporting of adverse event was compromised, except for routine immunization cases. Mild and moderate cases never ever been reported. And most importantly, engaging patient in their own care, IC plays an important role in local language, obviously. So we have observed reinforcement of medications, engaging patients in their own care. IC plays very, very, very important role. So IC is lacking behind in our public hospital systems in local languages. So I would like to hand over Dr. Amrit to discuss the key learnings after implementation of Sakushal checklist in our public healthcare system.
Thank you. The key learnings were patient-centric informed decision making, which is very much important and which was discussed today as well. Next is counsel the patient on medication safety using 5 moments for medication safety. We should be giving counseling to the patient on 5 moments for medication safety, which we have learned from that Sakushal checklist. Next is medication reconciliation. Next is fall risk assessment, which is very much important. Venous thromboembolism prevention plan, prompt reporting of any adverse drug event. It is also a very important point, and we should know this. Next is key improvements under facilities. Communication during intramural transfer. SBAR and IPAS has been implemented and followed. These are very important communication techniques and tools which we need to use. Next is identification of hazardous material. Listing of potential risk with route of exposure is documented. Safety data sheet is maintained. Next, safe patient handling is practiced. And next and last point is IAC materials for involvement of patients in their own care has been implemented. Thank you, everyone.
Thank you, Team West Bengal. Now I would request Dr. Vinita Dhankar to please present a small token of appreciation to Team West Bengal.
I once again thank you all the states for participating in presentation. Due to time constraint, we were not able to accommodate all the states, but the state who accommodated, we are very grateful to you. So ladies and gentlemen, as we draw the curtains to this remarkable event, we want to express our deepest gratitude to each and every one of you for being a part of this national level celebration of 5th World Patient Safety Day.
With this being said, I would like to thank our chief guest, all our key dignitaries, eminent speakers for the webinar, representatives of Ministry of Health and Family Welfare, representatives of NHSRC, representatives of all the states and union territories, our NQAS external assessors, representatives from development partner, academic institutions, for taking out their precious time out of their packed schedules. I would also like to thank our IT team, our admin team, and the team of Indian Habitat Center. At last, I would like to congratulate and thank the Quality and Patient Safety Division, NHSRC, and my co-host for the event, Dr. Deepika Gaur, as without them, this event would not have been possible. And I would also like to especially thank Dr. Abedaya for coordinating this event. Thank you all.
Now I request all of you to please rise and join us for National Anthem.
जन गण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगल दायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
Jai Hind. Thank you one and all. I'd like to inform you that the lunch is being served at Silver Rock Hall. And everybody, thanks once again. Thank you so much for taking out time. We are really glad.
Thank you so much.
These are for us.
ये